It's like this girl's clearly having psychology, but Rohana wants to meet with all professors. I know you don't work Mondays, but I still send it to you.
Yeah, that's fine.
And I can understand that you might attend it if need be, or you decline it if not. But Shanson straight away declined it.
I don't know. You see, I can't understand. And she's the one just for bereavement. I don't know what she has done. And he's doing a bereavement using visual. I can never go into visual. Yeah, hold on. I'll call you back.
Oh man, yeah.
Just because we can hear your conversation. Sorry.
Dennis, yeah.
I don't need speaker. Thank you. So that's all.
Do you know how many people are Okay, that's good. Hi everyone. I hope everyone can hear me okay.
Hi.
Brilliant. Welcome to our transition conference. Thank you for registering on. I'm Laura, I'm the Learning Disability and Autism Nurse with the HRUT. I Just thought I'd give some quick kind of housekeeping stuff before we get started, and then I'll hand over to our Chief Nurse, Catherine Halford, to welcome the event and open the event. So if you're not speaking, so for all our guest speakers, if you're not speaking, just to make sure that everyone's on mute, if you could have your cameras on, if you're in a position where you can, that would be brilliant, so we can see your lovely faces. And if there's any questions at all, sort of after each speaker has done their segment, then please put it in the chat. My colleague Abby will kind of monitor the chat and make sure that those questions are kind of fed back to the relevant speakers. And there will be a Q&A section after each speaker's 15-minute slot. So please feel free, have a think. If there's any questions that you've got, they will be answered as they come through in the chat. And thank you. So I'll now hand over to our Chief Nurse, Catherine Halford, who will open the event for us.
So I'm going to do a long walk down the boardroom so that perhaps you can see me better. My name is Catherine Halford and I'm the Chief Nurse at the HIUT. And as part of my workload, I'm part of the and I feel really privileged to have that with me. We've made such a lot of difference to patients in our last few years. It's really, really, really. So people who previously would have been really frightened and very worried about coming into the hospital, because of the work now feel less frightened. We've done lots of work with our consultants who are able to, oh, sorry, you can't hear very well, Harvey. Can we increase the volume?
The microphone's here as well. I wonder if you stand underneath that.
Is that better? Is that better, Parveen? Yes?
Yes.
Well, you can't see me as clearly, but you can hear me now. So I suppose that's better, isn't it? So I'll start again. My name is Catherine Halford and I'm the Chief Nurse at the HIUT. And as part of my portfolio, I have the learning disability team within that. And I'm very proud of the work that they've led over the last few years to make sure people who access our services who have a disability are supported. So people who used to be frightened of coming for blood tests, people who are worried about coming for operations, now aren't. They now feel confident, they feel well supported, and that's really, really good. But today we're talking about transition, and transition is really important. How do you move from children's services to adult services? And we're specifically talking today about learning difficulty. But for me, it's about how anybody transitions. I worked at the Department of Health in 2006 for a couple of years, and the work that I led there was around how children transition from physical health conditions into adult services. So I really recognise the work that's being done here, and there's lots of parallels. So it's really scary. You have a child, you are a child, you develop a relationship with the service, you know where you're going to come, you know the doctors, you know the nurses, you know where you're going to park your car, and suddenly at 16 that all changes. And moving to an adult service means that you don't know anybody, you don't know where to go, you don't know who you're going to talk to, and it's really important that we make that transition a lot smoother. So I used to be a paediatric nurse and I used to look after children with cystic fibrosis. I used to run clinics between 14 and 16 where we would run them jointly with the children's services so that people could move through. But we needed to have a conversation with everybody to say this is what we need to do. Your child is growing up, you are growing up, and you will need to move forward into adult services. And we need to make sure that transition is smooth, that you're comfortable with that transition. And I'm really pleased that this conference is going to talk to those topic areas, is going to explain how that happens, why it needs to happen. And also to help people, I think, move away from being so frightened. It should be quite an exciting part of people's lives. I'm moving into adulthood. What does the next part of your life look like? What are you going to be doing? So I'm absolutely delighted to be here at the beginning of the conference. I'm going to watch it remotely for the rest of the afternoon, but I think we've got some fascinating topics, some really interesting people, and I hope that by the end of the afternoon you really feel much more confident in either transitioning children who are currently in your services, or I know that we've got some schools and colleges with us today, transitioning your children into adult services. And if you're a child or a young person who's joined us today, that you feel confident about what that looks like in the future. So thank you very much indeed. I would just like to thank the team for putting on this conference because I think it's really, really timely and very important. And I hope you have a really, really interesting afternoon. Thank you very much.
Thank you,
Thank you.
Catherine. Thank you. So we'll now kind of kickstart with our first guest speaker, and we'll go straight into our first topic of the day, which will be what the role of the learning disability and autism nurses in transition in hospital. And our guest speaker for that will be our lead nurse for learning disability and autism, which is Tim Buck. Tim, I'll just get your slides up for you.
Thank you. Yeah, thank you, Laura. So just while Laura's pulling the slides up on the screen for everybody to see, my name's Tim Buck. I'm the lead nurse for learning disabilities and autism here at BHIUT. So I'm going to talk to you a little bit about what the learning disability team here does, and then talk through some of the stages about how the team support with transition. I've thankfully printed off some slides in front of me just in case we have any IT glitches. I think before I do start speaking, I would just like to thank Laura Adiefa personally for all the hard work she's put into preparing the conference today. That's the word. The conference today, but also there's been a lot of people supporting behind the scenes as well. So just to say thank you for the whole team for pulling this together. Can I just confirm everyone can see the slides on the screen?
No.
No.
No, we can't.
No.
Ah, okay. No problem. 1 second. Let me have a little fiddle. How about now?
Yeah.
Yes.
Hey, all right. So if I just play from the beginning, can everyone still see that?
Yes.
Wonderful. All right. Sorry about that. Technology gets the better of me sometimes. So as I was saying, my name is Tim Buck, lead nurse for learning disabilities and autism. I'm also the interim name nurse safeguarding adults here at BHIUT. But I'm going to talk to you about the learning disability team. So as you can see, that's a slightly squished picture of Laura, Abby and myself. There are 3 of us in the team. So as Catherine mentioned, we're based within the safeguarding team. There's myself as a lead nurse, but then we also have Laura on the left-hand side who leads on any projects in relation to children and young people, and then Abby on the right-hand side who supports with a specific focus on adults. We're here to support any patient with a learning disability or autism, or both, who access any of the BHIUT services. So that essentially means we're here for the patient. We're also here for the support network that surrounds that patient as well. So any family members or carers that are supporting that person, we act as a link or a liaison person to the hospital to get advice or support in relation to the patient, but also the teams both externally, so community-based learning disability services, for example, or social care colleagues, but also obviously our internal teams, so our medical teams and our nursing colleagues and allied health professionals, anybody working with that individual to offer support and guidance with a focus to reduce health inequalities, but also to promote reasonable adjustments and make sure that we're making small changes, small adaptations to how, as an NHS trust, we provide a service, but that make quite a big difference to the level of care that a patient receives. And those are our contact details. The reason we put them up there is because we share those with anybody that needs to get in touch with us. So please do jot down that number. If you have a family member or you're a carer for somebody with a learning disability or autism that you feel would benefit our support, please do either give us a call or send us an email, and we'll be in touch.
Tim, we can only see the first slide. We didn't see the second and the third.
Sorry about that. If I keep it in this view, can you see this slide now?
Yeah.
Okay, sorry about that. I'll keep it in this view and go through them one by one. So I'll start by talking through the role of the learning disability autism nurse in relation to transition. So I think first things first is to begin the discussion of what transition is, and that's usually started when the patient turns, or the person, young person, sorry, turns 14. And we'll start to look at the transition plan. Now, in doing that, the Trust have developed a transition plan template. So that's provided to the young person. And the idea of this document is they own that document, that's theirs. A little bit like if anybody knows the hospital passport, the transition plan is a similar type of tool, looks similar, has a similar sort of focus, but it's aimed at young people and specifically focusing on transition. So starting at that 14 years old, and they'll receive this booklet. And the idea is they take that not just to their hospital appointments, but also when they're at home, they might want to take it to any appointments they have at home to see their GP or anything like that, and make sure it's updated on a regular basis. They'll be given a point of contact in hospital for advice. So that will usually be a learning disability and autism nurse. And we'd all start thinking about referrals to the appropriate adult services. Obviously, at the age of 14, it would be too soon to start that process, but I think it's important to start thinking about what will be needed, and that's why it's important to start those discussions at 14. And also accompany the young person to any first appointments in adult services and start identifying those at that stage. So, like I say, the early stage is 14, which will start with an introduction to transition. So the learning disability nurse would meet with that young person and talk through the whole process. Something that we talk about a lot in learning disability services is jargon and removing jargon. And transition in itself could be a jargon term. So it's really important at that early stage that we explain to that young person what the word transition means and what that means to them, talking through each stage of the process so they understand what will happen when, to make it a less daunting process. We'll think about the knowledge around that person's conditions and the pathway that might be planned for them. So a lot of these early stage conversations will be done in partnership with the teams that are involved with them. Certainly the paediatricians and other consultants that might be involved in their care would be engaged at this early stage. And obviously the LD nurse will be kept informed throughout this process. And then the documents that I mentioned earlier would be provided. And also you might also want to consider a hospital passport alongside that as well. So at the middle stage, we start looking at between kind of 15 to 16 year olds. So kind of further understanding of the process or a review of the process so far is really important at this stage. Thinking about what to expect from the team that are taking over and addressing any wishes and wants of the young person. So at this stage, it's all about empowering that young person. If we think about the 15 to 16-year-old age gap, this is when things around consent and capacity start coming into play, particularly when somebody turns 16. And we've got a presentation later on in the afternoon which talks in more detail about capacity, but this would be the age range where we start thinking about really empowering that young person to be making decisions for themselves, and if they're not able to, thinking about the Mental Capacity Act and how that can be used to support that young person, but also keep those important people involved in the decision-making process. We want to start thinking about reasonable adjustments to make to help that young person understand the transition process. So, like I say, often we're thinking about how terminology is used and how we need to adapt to that. So, using adapting communication tools, perhaps, and thinking about other adjustments that might be needed to help that person through the transition process. And then any help and support the parents and carers might also need in preparation for adult services. It's really important to remember, or really important for us to remember, I should say, that parents and carers are such important parts of everything that we do. Although obviously our focus is on the person themselves and empowering them, we need to make sure that the important people in that person's life are involved in that, what we call a multidisciplinary team meeting. So where all the different professionals are involved, the patient might be there as well, but also that the important person in people in that patient's life. So whether that be their parents, their carers, or anyone else who's important to them. And then the final stages towards transition are around 16 to 18 years old. So confidence needs to be built at this point regarding the process, so that person's fully aware of who their lead healthcare professional will be if that's transitioning to a different person. At this stage, they need to be aware of that person's details, how to make contact with them, and that sort of thing. And the lead will inform the patient and carer of the time at which transition will be completed, and they'll arrange a handover between the relevant professionals. And the young person's first appointment with the healthcare professional to be present to ensure smooth transition. For example, a transition clinic. At a minimum, a handover of care is to occur between essential staff involved in the young person's care. So this stage is all about making sure that that person doesn't just shoot off into the land of adult healthcare without the right people involved. It's all about identifying who those people will be, supporting that person and their key network into that process by perhaps attending appointments with them, seeing the handover takes place effectively, and then hopefully waving a very gentle goodbye as they go off into adulthood. So that's a very brief summary of the stages of transition and the role of the learning disability nurse within that. The team here, we work very closely. So, like I say, we have a specific, one person specifically focused on children, one person specifically focused on adults. But we often share our caseload and keep each other informed of cases that are going on. So, from a learning disability team perspective, we can make sure there's a smooth transition. The plan that I just described is making sure that all the other people are involved also, and there's a smooth transition between all teams so that a young person feels confident and happy with what's happening. And the screen in front of you is just a demonstration of what the transition plan document looks like. As you can see, it's split up into the different stages to be completed as you go. So that's it for me for now. A very brief whistle-stop tour, but I'm happy to take any questions that anyone may have at this stage. If that's okay. What I'll do is I'll try and stop sharing the screen now if I can. How do I do that? Sorry. There we go. We can see. If anyone has any questions, if they'd like to put their hand up or just speak out, that's absolutely fine. We have Eva.
Hello, can you hear me?
Yes, we can hear you.
Yeah. Oh, hi. So I'm Eva Freitas Sanchez. I'm the strategic lead advisor for Redbridge, preparing for adulthood and autism. And I can see that this is really a very good plan that we have here. I'm a little bit concerned about the young people having so many sets of transitions. So I was wondering if it has been taken into consideration that they will have, obviously we were very close with social care at the moment in the SCN department, so we could have schools and social care, but has it been taken into consideration how we could do those transitions at once? And that is my question.
Yes, absolutely. Thank you. I suppose the process that I was talking through just now is specifically related to health. But I know as part of the preparation for this event, and I know Laura leads on a much more multi-agency type meeting. Laura, I don't know if you wanted to just talk through some of those stages.
Yeah, sure. Thank you, Eva. essentially what we do in hospital is we actually have a quarterly meeting with schools, some parents as well, where we kind of discuss some of the crucial things around transition, but also some of the needs of those children. And actually what you get from this conference today is actually people from, you've heard the hospital perspective, but you will also hear social care. You'll also hear from the community team. And actually, ideally, what it should look like for that young person is it's happening at the same time across those different fields. So this is, we're starting off with hospital because that's where we're based. But what you should see is actually what other services are doing at that same time for that young person. So hopefully it all come together.
Okay, it's just, I'm just thinking base, because obviously we are the local authority and we hold that education, health and care plan responsibility. And I just think it will be very important for us to be part of that further talkings or further meetings that is in there, if that's possible.
Absolutely. And what I can do actually is, if you don't mind, probably invite you to some of that quarterly meetings and get that sort of your input from that perspective. Absolutely.
That would be great. Thank you.
Yeah,
Thank you, Eva. I think Beverly Wilson, your hand was next, and then we've got one other from Liz Hunt.
Thank you. Can everybody hear me?
Yeah.
My question is regarding transition. I know we're talking about it, BHRUT. So what happens to a young person when they're actually also under different hospitals? Is any work of the work, are you actually doing collaborative working? So you have one transition pathway collaboratively, or is it going to be individual?
That's a really good question, Bev. So what would happen, because as you say, some children with a learning disability, they're really well known to tertiary centres, such as Great Ormond Street, Royal London, and the expectation would be, even though we would provide, if they came to us first at 14, we provide the transition plan, they would still take that plan to whether it's Gosh, whether it's Royal London, and actually they will also be thinking about transition. And it won't be to say they start a new sort of plan with them, but it will be to continue, and actually it would help consolidate to say, okay, at Queen's, this is what's happening, this is the neurology team that you're under. But actually when they go to Great Ormond Street, there's normally that direct contact with our consultant and with theirs. So there is that joint working. So it's not to say that if you're at Queen's, you only have a BHRUT transition plan, and therefore when you go to Great Ormond Street, you have another transition plan. It should be all along the same line. Yeah, we're all communicating for that young person. Yeah.
Thank you.
Thanks, Beverly. And Liz?
Hello, I'm Liz Hunt and I am Head of Service in Redbridge. So I'm responsible for everything to do with 0 to 25 SEND services. And what I'm just conscious of, and I'm conscious of it really from various experiences that parents have shared with me, is that many of us, including yourselves, are very focused on how we can support that young person really from age 14 going in through to transition. The problem is that I think multiply that person has transition conversations at age 14, at age 15, at 16 and so forth, with many of us in the systems, the education, health and care systems. And it doesn't feel from a young person and a parent's view that it's coordinated, that actually we are all having these conversations, but we are having multiple and sometimes duplicate conversations from their perspective. And I guess it's about, we're all aware of how important transition is, but how can we have an integrated transition process rather than a multiple transition process, which I think is what we probably are having currently. So I guess that's a challenge for all of us here.
It's a really good point, Liz. Thank you. And I think just if you don't mind me chipping in, Laura, I think part of the process that we would like to shore up, and the meetings that Laura was just describing, is how we can work collaboratively, because like you say, there are often many different people involved, and particularly for young people with learning disabilities, we know that people are more likely to have multiple health comorbidities, and like Beverly pointed out, they could be from different hospitals, different specialisms. So I think what we were hoping to do partly from this conference, and hopefully from seeing the agenda unfold, it might answer some of our questions about how we work together, seeing the different agencies that are involved already. But then also, yeah, I suppose we'd be keen from this conference to think, like you say, about how we can link up and make that process stronger, definitely. Is that what you do? Thank you. Laura's our transition lead, so I don't want to speak for her, but thank you. And then I'm mindful of time, so if we could maybe just have these last two hands, so Karen and then Naveed.
Hi, yeah, I'm a parent of a young man who's now just turned 20 with a learning disability, and I'm also from the Parent Forum in Havering. Apologies, I missed the beginning of the slides because I couldn't get in, so you may have already said this, but I certainly, George has got, he's with Great Ormond Street, or he was with Great Ormond Street, he's with the Royal London. He's also using services at Queen's, and I have never ever had transition mentioned to me by any service that we are under. So I don't know if when you were talking about transition and the transition, you know, looking at how you get into adult services, whether that was for people under continuing healthcare or whatever, but certainly for the services that we've used, transition has never been mentioned to us at all. So, and as part of the forum, I'm not aware of any parent ever mentioning transition services to me. So is this something that new that's going to be starting, or is this something that should already be in place, or is it for some people?
So this is, I mean, this is something that has been in place for a little while. I can't speak for to go far back as when your son reached transitions age. I suppose what will happen from our perspective in terms of triggering those conversations is any patient that's been referred to us. So anyone that we're aware of that turns 14, we will start that process then and start having those conversations and linking in with the other, the schools and other hospitals that are involved to make sure, and social care and all the right people are involved. What I did do right at the start of my presentation, though, is give out the details for our team. So the slides will be shared with you. So if your son is known to be HIUT, I can only apologise that that conversation hasn't been held with you so far, but we're certainly available to support if he comes and accesses our services.
Well, yeah, because at this stage, I have no idea whether we're being passed over to adult services, whether we've already been passed over to adult services. I have no idea. Okay,
I think it's probably best, aside to this meeting, if I send you my contact details, or you receive them as following today.
Details, Tim.
Perfect. Yeah, if you let us know, then we'll be in touch and we can support, definitely.
Okay, thank you.
Thank you. And then Naveed.
Hi, sorry, my husband had to leave because he had to attend another meeting. It's regarding our daughter whose transition process started last year, and we were given the impression by the social services that the transition, everything is in place, the package is in place, the funding is in place. And we were quite happy because my daughter, because of her special educational needs, she won't be continuing with education, i.e. university or anything. She was given a place at Eastway, and we were again given the impression that everything is in place. We had a visit at Eastway, and they told us that she's been given 3 days in a week to attend Eastway on regular basis. And only recently we came to know that that thing had not happened. Although she was transitioned on 30th June 2020, she was never allocated a social worker. She was never allocated a care coordinator. I'm trying to contact them since 30th of June, multiple calls. I'm a working parent. I'm a doctor myself. I always don't have time to be on the phone for so long. I'm trying social services. The the duty social worker, they don't pick up the phone. Then I have to escalate it on the reception desk. They have to ask the manager. So it's just so many issues going on. Since 30th of June 2020, there was no contact with us. We've been trying to contact them, and they're just very, I'm very sorry to say this, but they were just messing around with us. So it was at the end, only recently, one of the social worker managed to contact us yesterday that she's going to put forward my daughter's case so that she can be allocated 5 days, because we are working parents. Iman has finished school, my daughter, she has finished school and she's at home. Ideally, she should have started Eastway by now. So my husband and I, we had to take leave just to look after her. And the person that we are talking to, they don't even know if my Iman is a girl or a boy. They have not read the case. So it's just so frustrating that I can't even explain. I can actually go on for hours just to let you know about the problems that we faced in the last 1 month, because we were given the impression by social services last year that everything is in place. We will be contacted by Seven Kings cluster team, and things are going to happen in the way that we were expecting to. But I mean, parents are already overwhelmed with this transition process. I mean, it's so emotional for us already. And then we have to fight for this. I mean, it's not fair on us. And then they say that you can't have 5 days and then you can only have 3 days. I mean, how can I look after my child and my husband when we are both working parents? So it's just horrendous experience, and we really wanted to share it with us so that we don't want other parents to go through this, what we are going at the moment.
Of course, I'm so sorry to hear about your experience. I'm hoping today's session will kind of explain what we would expect from the transition process. And as I said to the previous person, if there's anything that we can do to support, please do contact us for individual cases. We can obviously, if they're known to health services, we can get involved and support with making sure you've got the right process in place and the right people are involved and the right contact details and stuff like that. Thank you. I'll end my Q&A session there, if that's okay, just because I'm mindful of time, and I'll hand back over to Laura for the next step.
Thank you, Tim, and thank you for your questions. I'm just conscious of time, as Tim mentioned, in terms of our programme. And I think our next speaker is Dr. King, and he's our paediatric consultant, and he will be talking about the role of the paediatrician in transition, obviously in hospital. But just because of time, as I said, we're a little bit behind schedule. If there's any questions, please put it in the chat so we can kind of facilitate that effectively. And Dr. King, I'll just hand over to you. Are you okay sharing your slide from your end?
I can't see the button to share the slides, but I have received an email about it. Do I just click on that email?
Next to the mic.
Sorry?
Where the mic icon is at the top,
yeah,
next to the leave button, it's a little arrow facing up, and it's just for you to share your content. Can you see it?
No, I can't, I'm afraid. I can't see that icon at the top.
Fine. So on the top of your screen, can you see the leave button? To leave the conference, don't press that.
No.
If not, I can share it from my end, and you just
Yeah.
kind of have to.
Yeah, I've got them here, but I can't.
That's absolutely fine. I'll share it from my end, and then.
Hello, my name is Morgan Keane. I'm a paediatric consultant at BHRUT. I've been working here for about 20 years, so I have seen many young people coming into their teenage years and then moving onwards from pediatrics into adult services. I've seen some situations where that's worked very well for patients that I've been looking after as a pediatrician. I've seen other situations where it's more complicated and maybe hasn't worked as well. So I'm just going to talk a little bit about the role of nutrition in transition. If we could have the first slide, please, Laura.
Yeah.
So there's various definitions for transition, and I'm sure that everybody is quite aware that transition is a movement, and in this context, it's movement from children's services into adult services of a young person. And transition is a process, and transfer is an event rather than a process. And obviously, sometimes we transfer children, young people, to adult colleagues without a great transition. At other occasions, the transition is very seamless and very good. So just be sort of talking about these concepts during my presentation. I found this statistic from a paper that I looked at from, I think it's from the Northeast, that in a typical NHS trust serving a population of 270,000 people, there will be approximately 100 young people with long-term health conditions reaching the age of 16 each year. So our trust obviously serves a larger population. So probably we must have between 200 and 300 young people. Now, some of those young people will have conditions such as diabetes, epilepsy, severe asthma. Some people will have obviously other neurological conditions, cerebral palsy, people with learning disabilities who may have medical comorbidities, medical problems with their learning disability, people with autism who may have epilepsy or may have other medical conditions associated with. So we can see that in our area, there's probably a large number of young people with these long-term health conditions. So I'm really grateful to Laura and her team for setting up this conference, because even though we're in the health service, we often don't know what's out there and what's there in the future for the young people that we're looking after when they're coming into their teenage years. So this conference is also helping us in the health service to understand what awaits the young people when they move from children's services into adult services. Next slide, please. So the body that pediatricians that educates pediatricians, and that it's not a regulatory body, but it's our body it's our professional body, has developed guidelines for transition, and these are our 5 sort of principles that they have from the Royal College of Pediatrics Child Health. Is that, 1, it's person-centered and appropriate to the development of the young person and reviewed regularly. So trying to individualize it. 2, that it's following existing guidelines and good practice, which I'll mention in the next slide. Involving young people and their families in decisions about their care, obviously, and sharing information effectively between the child and adult service. And the 5th one is that the commissioners and service planners play a very important part in this, because they will commission services, they will be paying for services, they'll be finding the funding to fund these services and these individuals who are going to help with transition of people with long-term needs, with the medical, learning disability, autism, or whatever. Next slide, please. So the standards that are out there, so the College of Pediatrics has their own standards, and in facing the future, they have standards for children and young people with ongoing health needs. There is a NICE guideline and NICE quality standard. There's also this CQC from the pond into the sea document, and there's another document which I haven't seen, which is for the Council of Disabled Children, and that's also regarding transition. Obviously, some of the resources and standards will not be completely relevant to medical people and nursing people that are looking after health needs. Some of them will have to do with education, with housing, with employment, and with those sort of aspects of a young person's life, not purely focusing on the medical issues that they may have that need addressing. Next slide, please. So just looking at the College of Pediatrics the Facing the Future document. So again, they're saying that the young person is supported with a coordinated package which starts in early adolescence and occurs smoothly, and so that's what should happen. Unfortunately, doesn't always happen, and hopefully will happen more in the future. as we get our act together. That we improve health outcomes and prevent clinical deterioration at the time of transfer. And this is very important for lots of conditions, because conditions can worsen in the teenage years for various reasons, because the young person has had the condition for more than 10 years, because the young person maybe is not able to look after themselves so well, because the young person is undertaking risky behaviors. Teenagers like to, push the boundaries and may not be sort of complying with their medication, complying with what their parents want them to do, complying with what their medical professionals and nursing professionals are asking them to do. And then enabling the young person to become more responsible in managing their own care as their development capacity allows them to. So this will depend on whether they've got a learning disability, to what extent they've got a learning disability. They may not be able to carry this out, but obviously we have to try and empower young people as much as possible in managing their own condition and understanding, as far as they can understand, about how they can help themselves as they move forward. And the College of Paediatrics very much emphasizes the importance of a key worker in transition, a point of contact in this process. Next slide, please. Sorry, I can't use the technology, Laura. And then the NICE quality standards, again, emphasizing that transition planning should start by age 13, 14. There should be a meeting to review the transition planning process. Again, identification of a key worker, meeting the adult services, not just transferring over and saying you're going to meet this doctor or nurse next month, but actually meeting them, preferably with a member from the child health team. And then if the young person does not attend their follow-up appointments with the adult services, there needs to be some process there that this can be mitigated against, to prevent them falling through the nets and being lost. And that's particularly relevant to some specialties where people can just disappear and then they turn up when they're in their 20s with lots of problems and complications. Next slide, please. So the role of the pediatrician, I mean, first of all, obviously identifying young people who need transition and starting the conversation early. So this seems like a simple thing, but actually it can be sometimes difficult to work out who you need to transition, who needs to move, and it can be difficult as well, because the years go by quite quickly from when you're looking after a young person, and suddenly they're teenagers. The next thing they're 14, 15, and turning 16. So I think pediatricians sometimes need reminding, and that's the good thing about having people like Laura within the trust, and her predecessor. They were very good at reminding pediatricians that actually this young person is now becoming a young adult, and we need to think about what the transition is. Next slide, please. So planning the transition, so who to involve, where to refer. So this is not straightforward for young people that have got many health needs. So I think it was mentioned earlier on by Laura, by Tim, that some of these young people will be under Great Ormond Street, Royal London, different hospitals. They'll be seeing different specialists. They might be seeing neurologists. They might be seeing endocrinologists, various sort of professors here, professors there. So working out about who to involve in the ongoing care of the child will involve some discussion with the tertiary hospitals, but also needs to be pragmatic and involve the local health services as well, because obviously it's all very well for a young person to be under a tertiary hospital in the centre of London. If they become unwell in the middle of the night, they're going to come to the Queen's or King George Hospital. So it's important to involve local health services as well in their ongoing care. It's often important to involve the GP more and to get the GP more involved, because sometimes in paediatric services, the GPs are not very involved because the child or the young person is coming to the hospital all the time for their appointments, and GP may not see them very often. So who to involve, where to refer the child, that needs to be a discussion with the family, with the young person, but also with the tertiary unit the child has been under, what their plans are, but also should involve, especially in a child or a young person with learning disability, the learning disability service about what is pragmatic and what is sensible for that young person in terms of who to refer the person to. Next slide, please. So the team approach, I've just mentioned it already, it's just ongoing from the last slide. This is where involving the specialist nursing teams, so for example, a young person with epilepsy, involving the specialist epilepsy nurse in our trust, young person with other health needs, involving the multidisciplinary team to make a good transition to decide what's right for that young person in terms of who they should be seeing, who they should be referred to, what clinics are advisable for them for the future. Next slide, please. And then obviously transition we've got to remember as well, because sometimes pediatricians and doctors think that the transition is just about the outpatient clinic, but we need to think about the emergency department. So has this young person got a specific plan for when they come to the emergency department if they've got a specific medical need like epilepsy? We need to involve the ward. One of the big things which Laura's predecessor, one of Laura's predecessors, Alison, did was to ensure that the young people with learning disabilities could have family support and presence when they were admitted to the adult wards. GP, obviously, I've mentioned is more important. GP is now more important than before, and may involve other areas like pharmacy, and ambulance and transport services. Next slide, please. Next slide, please. I don't know if you're able to change the slide, Laura. So my next slide is about joint clinics. So ideally we have a joint clinic, and I've attended several of those in different areas, particularly useful in young people with epilepsy or with diabetes, those kinds of conditions, to introduce the young person to the adult team. Unfortunately, joint clinic sounds great, but it's actually logistically quite difficult sometimes because people have different schedules. It can be difficult to actually set up. Sometimes instead of a joint clinic, we have a meeting where we discuss the young person, and again, the learning disabilities service has been very helpful in setting up these meetings where sort of different specialists from the adult service can meet the pediatricians and the pediatric nursing, child nursing team to discuss about the young person. So this is the ideal, if we can sit down and discuss rather than just sending a letter of referral. Next slide, please. So the communication obviously needs to go in various ways. First of all, we need to communicate with the young person and family about the process. They need to know that transition is happening, what this involves, what the options are. Sometimes young people will be going to live away from their family in a different place. It might be a different borough. So, it may not be sensible for them to be coming to a clinic or a hospital service where their family are. They may have to be referred somewhere else. Obviously, good communication with the adult team, with the GP and with the emergency services. The emergency services need to know as well. There may be a sort of a letter that needs to go to the ambulance service about a young person's specific health needs. If the ambulance is called, the ED, if the young person comes to the emergency department, what needs to be done, who needs to be called. So good communication, obviously, highly important. Next slide, please. So downsides. So there are obviously some downsides with all this. You know, pediatricians may find it difficult to let go and also to deal with young people who are approaching adulthood. So sometimes if pediatricians have been looking after a young person since they've been a baby or a very young person, they tend to sometimes treat the young person the same way, even though this young person is now approaching adulthood. The young person is seeking to have more independence, and so pediatricians can be that can be difficult for us to, and also, as I mentioned, to realize that time is going past really quickly. We need to make some plans with this young person we're seeing every 6 months in the clinic. Where are they going to go? What's the future plan? Families may have expectations which the health service can't deliver. So obviously, you know, sometimes children are under lots and lots of different specialists at children's hospitals. They're seeing professor this, professor that. They're having different tests. Sometimes they've got conditions that are very, very rare, and you know the tertiary hospitals are very interested in them. When they get to a certain age, the tertiary hospitals say, well, they're too old for us now, and they may not get the same treatment or sort of interest from doctors and from health professionals. And then, you know, the apart from that, the services may not be there that they've got grown used to in the children's hospitals. So this is something that we have to be realistic about. Having said that, having a local person in their local hospital may be much more convenient for them rather than having to travel all the way into central London to see Professor so-and-so every 6 months. So there may be benefits as well to now having a local team looking after you. Now, the coming out of that, the adult teams may struggle to offer the same individual care and to get to know the young person and family, because obviously, as pediatricians, as child health professionals, we've seen them growing up. You know, we know the families get to know the families quite well. But the adult team, this is a young person coming into them. They haven't got the same knowledge about the young person, so that's a downside as well. Next slide, please. I think it's nearly finished now. I think this is the second last slide. So I'm sorry about the transition of the slides is not smooth. I couldn't find the technology, the button to be able to share the slides. But that's really concluded the talk. There's 2 more slides, but one of them is just the acknowledgements of where I've got the information from, and one of them is just a poster from made by a young person about what was important to them. And I think the poster sort of says to health professionals to more or less take them seriously, talk to them. I think it says knock on their door if you're coming in to see me in the hospital. And there's various other things which is important to the young person, and we sort of need to keep that in our minds when we're doing all the transitioning of these young people. What's best for them? Try to involve them in the discussions and in the plans, so they feel ownership of the transition process. So I'll conclude there, because I know that we're running out of time, and open you to questions. And share the you can get. I think you can take the slides down, Laura. They're just my thank you. Thanks everybody, and sorry again about the transition of the slides. Thanks, Laura, for changing the slides around.
Thank you, that's keen. Sorry about that, guys. IT's not mine. Conscious of time, so just a couple of questions we'll take so that we can get through. I think we've got some questions in the chat. One of the questions was, what hospital is Dr. Keane based? So he's based in BHRUT.
Queen's and King George Hospital.
And then we'll take a question from Beverly.
Good afternoon, everybody. Just want to say that was. Can everybody hear me?
Can I phone you back?
Hello?
Yep,
Oh, you can. Just want to say that was an excellent presentation, Dr. Keane. Thoroughly enjoyed it, very interesting. One of the things I would document it down is it's actually linking what everybody's been saying. Tim, you mentioned about the transition plan, that paperwork you had on in your presentation. And Dr. Keane, you mentioned about transport services and pharmacy. And it's about, for me, it's how do you get all this information coordinated for the young person, because it's all relevant information. You know, you mentioned about the pharmacy and all that type of thing. How do you bring it together on your transition pathway or plan, what you mentioned earlier?
I think it's from my point of view, when I'm thinking about transition, it's quite bespoke to each individual young person. So I mentioned pharmacy because there are some young people that are on very complicated medications, and you've got to think about how you're going to sort that out in the adult wards. You know, where they're going to have that done, if they're coming in for infusions or coming in for specific treatments. Transport, obviously, I think that's probably not something that I would be organizing, but I think ideally we would have a meeting to discuss all these aspects. But some things fall into place. Sometimes the families will also have ideas about how things can proceed. But I think from my point of view, the most important thing is finding the right person, right team to refer the young person to locally. Because some young people may be under, as I mentioned, under children's hospitals, but they're quite far away. And who is the right person if the young person is under lots of different specialists there? And that's where we need some discussion with the family. Also, someone like Laura from the Learning Disability Service to discuss that and make a sensible, because there's no point referring a young person to 10 different specialists at the Queen's. You know, they'll be up and down to the clinics. They'll be in a clinic every week of the year, and it may not be helpful to them.
If you don't mind me adding as well, I think Beverly, just to add to that, and I'm getting a sense that this might be a theme of the concern throughout the day is how do we coordinate all these different teams? And as Dr. Keane mentioned, I think having that meeting is one of the key parts of the coordination, in that if you get the right people in the room, so as Dr. Keane was saying, if you have for example, somebody from the learning disability team, as well as other organisations, you can have that discussion as part of the planning process to think, who do we need to be involved and who's going to be responsible for contacting that person? You know, who's the right person to be doing that bit of liaison work and things. So I think that would be one of the plus points of having a transition plan and having that document. The idea of the document is it just writes down what's been discussed and what's been agreed, but then the meetings that you will have at incremental stages throughout the transition will identify whether additional people need to be brought in and how you go about doing that.
Thank you. Thank you. Just because of time, I will have to press on for our next speaker, just because of the time slot. Liz, I do see your hands up. If you could put in the chat, and hopefully we can come back to that. You're on mute. You're on mute. Sorry.
Sorry, my hand is up because there's a problem with accessing chat for several of us. I've had a message come through to say that we can't access chat. So that's why I put my hand up to say we would like to, but we can't.
Yes. No, that's helpful. That's important to know, actually. I'll send a message to Charlene. Hopefully we can get that sorted quite quickly. She's on it. So we'll sort that out. Thank you for that. Thank you, Dr. Keane. That's really helpful.
Thanks Laura. Thanks, everybody. Apologies again for the transition of the slides.
Thank you.
Thank you.
We'll move on swiftly to our next speaker. We've got Dennis, who's our community learning disability, specifically transition nurse, actually. So Dennis, if I have you on screen, and if you could share your slides, and actually probably be easier for you to control from your end. Dennis, can you hear me? You might be on mute.
Yeah, I can hear you, Laura.
Perfect. You okay sharing your screen?
Yeah, let me come in.
Thank you.
Can you see my screen? Hello?
Yes, we can
we can see it.
All right. Good afternoon, all. My name is Dennis. I'm a community learning transition nurse for adults in Redbridge service. Here, I think we've had a lot of discussion regarding transition, of which have taken place, but I would like to emphasize that most of our transition are taking place with the children's services. So I work with them in terms of transfer when we always have a regular meeting once in a month where transfers are made to the adult services. However, to the learning disability service, there's a different way of way that transfer or it being made. I will come into that. See here regarding to transition, with the children's service, they always kind of have a transition assessment in place, educational health plan, support plan. School is also involved together with healthcare professionals, the GP and others, and also the children's, the pediatric service also. Advocate and the continuing healthcare is being done, of which if I'm required or my help is required, I do come in to support them with that. As we know with transition from children to service adults is often very challenging, has been discussed before, into learning disability and their family, which has always been a problem. There's always been a lot of gap. It combines a lot of changes of service and professionals at the very time when they are negotiating the wider change to their own life. At this particular time, they will be changing their profession, which they have in the pediatric, which they've known for a very long time, to an adult service or a GP, which actually they don't know about. It actually takes time to actually get used to it and others. And these are part of my work, kind of working with the GP to kind of make sure that transition is being facilitated and support them to settle. And it is also very important that when a young child, when reaching the age of 18, there must be a similar transition, as also been said before, handover or health and social care needs between children to adult service so that there is no gap in the service. This gap have been a problem in the past, whereby a lot has been transferred, but they are not known to our services. For example, documented transition plan that include their health needs. This has always been a problem regarding to the children's service, especially from the pediatric aspect of it. The handover that do come in has been a problem. They do just hand over to the doctor or to the GP, whereby we doesn't get those documents. I'll kind of be in to kind of looking and getting these documents so that I'll make a complete transfer when it's accepted to the learning disability, the adult service, that these documents are available. And sometimes these documents are needed in terms of to meet the criteria of acceptability to learning disability criteria in the Redbridge. My role as a learning transition nurse is to coordinate transition of young people from children to adult service. I work closely with the school nurses and other healthcare professionals, especially the children's service, and also with the pediatric nurses, some of them, to make sure that the transition is well planned and well in place. And also to ensure annual health check is carried out by liaising with the GP. These are the points that they've been transferred and it's now in adult service, that the annual health check is very important, that enable us to keep them out of the hospital. And in most of these times, I liaise with the family, whereby in a situation to explain to them, I will remain their coordinator during this transfer and during this period, whereby I will transferring or referring to other service or professional that will be involved. It's also my duty to facilitate health facilitation, which will support carers, parents, and also people with learning disability to access the mainstream services. Ensure reasonable adjustments are provided to ensure that hospital passports are completed. Reasonable adjustment is legal, that every organization, trust or wherever, or GP or hospital must give reasonable adjustment to people with learning disability. That is changing the way of which we can support them to meet the service, the benefit of going to the hospital, just like every one of us. Then the hospital passport is more like a document that gives everything about them that enable the hospital, the nurses, the professional, whenever they are admitted to the hospital, to kind of have what to do, know about this person. It's more like kind of a document that gives much about them, both health aspect while how to communicate with them, how do they feel. It's more kind of a personal passport that actually enable the clinician to care for them without waiting for their parents or for their carers. As a transition nurse, I still have a key role whereby I liaise with my colleague in the hospital. Like I have a lot of colleagues in Queen's Hospital, King George Hospital, and some other hospitals that we work with to make sure that the health of people with learning disability and their needs are being met. And also participate in the proactive and coordinated care plan in addition to future planning for the service of people with learning disability. I also promote their rights of people with learning disability from discrimination, and also acting on the valuing people, which stated that which mostly are promoting their choice, their independence, inclusion, and better life chance for people with disability, supporting the carer and also the parents, and improving healthcare for people with learning disability. It's also my role to provide support in completing the CHC check. What that means is that for those that need it when it's required, it's a checklist for NHS completion if they will have a support from the NHS funding or it's going to be local. So I help to support, to coordinate and prepare this by working with the multidisciplinary team in providing necessary documents for the assessment. That is providing any evidence that will support them to meet the criteria. I also carry out a health assessment and providing health intervention and specialist support. My own case in this problem is that I have to carry out an assessment. In my own assessment, it's more like kind of a physical health needs. But as a learning disability nurse, as we all know, in the community, we remain the doctors, the nurses, and all that we have to carry out a holistic assessment to look at the mobility, the communication, the bowel movement, and all in general, all that has to be done. So in this assessment, I will be able to make a recommendation or looking into it, who to be referred to, who is the best to manage this problem, who are in position that can refer to, that can be part of it to support that we can meet the needs of this young man. It's also my job to ensure that the LEDA process is being followed and necessary procedures are being met. LEDA is a process whereby people with learning disability who died in the hospital, even at home, need to be reported, and also there should be an investigation. The investigation is no more of a blame, it's investigation to know where we made a mistake or whoever that was responsible made a mistake and how to support. And also it's my responsibility as a transition nurse to gap the bridge, which has always been a problem between the children's service and the adult service, where most of them have been kind of fall over, whereby some of them have not been known till when they are age of 70, some 60. So it is my role to bridge this gap that I remain as a coordinator for them. In Redbridge, we have a different criteria. This is where it kind of be different from others. I will not be talking more of learning disability because a colleague will be discussing about that. Here is only regarding criteria to our learning disability service. Adult with learning disability, we start to a referral from the age of 17 and a half, where the referral will be screened with the MD team referral meeting to establish if the person need can be best met by the specialist LD service. If the referral is accepted by the LD at the age of 17, it is also the responsibility of the children's service to continue to care for it. However, still be supporting them, since I'm aware of them as accepted to our service. But from the age of 18, whereby I will complete a full assessment, then I will now be signposting it to other professionals who be best in position. I mean, if their input and need, those who will be responsible, if to refer to a different trust or a specialist, this at the time I will be completing this, that will be fully involved. When the young adult continue to access our service until the age of 25 and has an access to OT, SLT, physio, nursing, and other professionals within the establishment, LD service will require a referral when being discharged from this service, unless in a situation whereby at the age of 18, it has been referred to us and we accepted it and we are working collaboratively with the children's, with this pediatric, there's no need for a referral. It's a swift transfer whereby we will picking it up. There are some of them that not known to us during the pediatric, they just discharged with not knowing, and the time we know become a long time, and this has been a problem. So what we're doing now is try to work with the pediatric. I'm already working with the children's service and other professionals, that anybody that has a learning disability before he's been discharged, that we are involved in supporting that client, that when they are discharging, so we're able to pick it up from when they stop without falling through the gap. Also, there's a lot of evidence during our referral meeting that to kind of establish if it's going to meet our criteria, if learning disability will be able to support this person. So a lot of evidence is needed. In most cases, communications are always being the best. We had a communication with the referral, with other parents and other health professionals. However, this is where the problem lies, that we find it difficult to actually communicate with the professional who were involved before, and sometimes we will not be able, and thereby making the referral a bit longer because we are not having any evidence or a response to kind of speed up the referral process. Here is some of our LED criteria. I don't know, I have to read all this out. These are the criteria to meet our services. So the slide will be available if anybody will need it. So I'm not going to go much maybe talking about that. However, cognitive assessment report. However, we're talking a cognitive assessment report. We do not really use a cognitive assessment report. There are other assessments that have to go in. We have the speech and language therapy report, which is very authentic. We have the functional skill, psychiatric report, psychology report is very, very important. Even neurology also can also give us some input of what happened. Pediatric assessment is very important. Sometimes we find it difficult to get. So early diagnosis made by other professionals is also very important, but this is where the problem lies. People with learning disability in the children's service hardly have any diagnosis, whereby make it not difficult that coming to adult service, we have not to kind of work hard to get an evidence, do an assessment. We do screening to kind of find out if the person is going to meet our service, or if our service will be the best place for this young child, or if we are able to meet his or her needs. Here is a referral to the learning disability service through RedBridge. However, here, like the social worker, another healthcare establishment that we work together with does not need to use its internal referral, which go to the learning disability service referral buses. That can be picked up easily by any professional on duty. However, those that are not new to us, like from other borough, they have to use RedBridge My Life, calling this number or completing the form, which actually will be completed. It will be sent down to our inbox, whereby we'll pick up, and whoever is on duty will process it for acceptance, whatever. Next slide. Sorry, my slide is spoke. The next slide is what happens when the referral is accepted to LD service. I've heard a lot of clients, parents, carer complaining that they are not aware if they are accepted to our services, whereby sometimes they have to tell them they've not received any letter. What we do, whenever any people with learning disability refer to us and accepted to the service, what we do, when it's accepted, we will send a letter to the GP, we send a letter to the referrer, and also to the parents and the patient or client, to let them know that we're informing them that it has been accepted into our service. So in this process, whereby I will be picking it up, to do an assessment. Some have been sent to us on the ground of accepting it without not professional being involved or referred to. However, I have to carry out an assessment to find out that if there will be other professionals that will be involved, and that is my role that I'm doing and I will continue to support. There's also the myth or the problem that what happens if it's not accepted. In this case, kind of being difficult if it's not accepted. However, we always sit in this meeting to look at it and see where is it best if it's not accepted. We post it directly to other professionals who we best believe will be able to support and manage or support and meet the needs of this young person. And the family will also be communicated, the GP and also the referrer, let them know of our decision regarding this. We still have a joint screening. In this process, it comes in a process whereby people with learning disability or a client is having a dual diagnosis. There's learning disability, there's no question about that. There is mental health also. In these circumstances, it's a way to look at it, which service will be in best position to actually support this client and meet the needs. A decision has been, we do the screening assessment, and they will sit down to discuss and see which service will be best to meet the needs of our clients. And that will be the best decision. Sometimes both of us do involve if it's required to support this client. I don't have much. That's all for now. Thank you. If you have any question.
Thank you, Dennis. Thank you.
Thank you very much, Dennis. That was very insightful. Someone asked a question. I'm just going to read it here. It said, how long is the waiting list for the referral? Can this be done within a few months with more children?
No, when it's accepted to us, I mean, when can we change the screen from this way? All right, you see the different thing here. When it's accepted to us, like learning disability, especially in the transition area, I'll pick it up, I'll book an appointment immediately to assess the physical health and also carry out a holistic assessment. During this assessment, wherever that come up, which might be having a dysphagia or wherever it might be mobility problem, and we know a lot of our clients do have a comorbidity like epilepsy and all that. It's also my responsibility to kind of refer it and contact the professional who is involved. And I also inform the parents, and sometimes I do kind of share my referral with them to other service to let them know, and also make them understand that I will be the coordinator. So if we talk in terms of referral, it depends on which referral is talking about.
Thank you for that. Dennis, can you stop? Can you exit your the screen? You're still sharing your screen.
There you go.
Yeah, better now.
Okay.
Someone asked about the referral for Avery. We've got someone from Avery amongst the speakers, so when they're speaking, they might be able to share more light on that.
In terms of Havering, I think I will allow that to my colleague, Nicholas, who is in Havering. She should be able to give more details about that. I work in NEPS, but I cover Redbridge only, the 4 cluster of Redbridge.
Thank you, Dennis. Yeah, we'll definitely cover that as we go through. We'll move on swiftly to our next speaker. We will have a comfort break coming up soon, so don't worry. Our next speaker is going to touch on the role of children and adults in social care. And we've got Sarah Toure, who's a consultant transition social worker. So she'll go next. Thank you, Sarah. Lovely. Over to you. Your slides are up, so yeah, when you're ready.
Hi, everybody. My name is Sarah Toure. I'm a consultant social worker in a disability service. I don't think you can see me properly. It's too, oh, I don't know. Okay, that's better. Yeah, from the disability service. And okay, I've been invited to talk to all of you about transition and the role that I play in it. So I'm going to start. So let's get to the role of the transition social worker. The role of a transition social worker is a special needs role that I have. Transition social worker my role involve coordinating support for children age 16 or 17 and that are transitioning into adulthood. The function of having a transition social worker is to ensure the delivery of a streamlined service from children to adult social care. I don't know if you're aware of this, but children in Barking and Dagenham, where that's the borough I work for, the children's services, disability children's services, and adult have formed one. So we have one service now. So the main purpose of a merge between children and adult services was to remove the cliff edge, where children will often reach 18 and services provided by children will fall away, creating a gap in support. So transition assessments will determine what adult social care a young person might be eligible for once they reach 18. So together with the family and other professionals, family are empowered to make informed choice about the future of the children, family, and the young person. All together are usually empowered to make decisions about the future and can prepare for adulthood. Okay. I work in partnership usually, okay, which is best practice really, with agencies such as school. I have Trinity, which is a special education needs school. And I work with day services, meaning we have the IFWE, we have IFLAND as well, and health services, education as well, and social care to identify the young people who will be moving into adulthood and needing services and sometimes further education as well or day services. The young people's needs are usually holistically assessed, and they are offered a personal budget following the assessment or a direct payment, which is generated from a different funding stream to meet the identified eligible needs. And I mean by mainstream services, education, social care, and health as well. The transitional support plan is person-centered and is outcome-focused always to promote welfare and independence. The plan is also jointly formulated with parents and the young adults. And I will try to give you an example here from a real case. I've been working with a young person who was in his late 16, turning 17. So I started the process of planning his transition together with the children's social worker because he was a looked after child. So that allows me to start building up my relationship with the young person and getting to know the parents, trying to understand the needs of this young man moving forward, because needs do change because you become an adult, so you have more, your need change. So we start in the planning early enough, which is key for a successful transition. And I started looking at the young person accommodation need, future accommodation needs, and thinking about as well the education need, working together with the EHC team in Barking, and thinking about the ability to socialize with young people, like forming relationships. So you start to think about day provision, and you start to encourage parents to go and visit certain school or certain day provision so that they can make a decision together. And then the transition can start between services. So yeah, I thought I tell you a bit. I work with young people, and then from completing the holistic assessment, I don't progress to a support plan. But before that, I need to come up with a budget, which is offered to the young person and the parents, and the decision are made around how they want to manage the budget. So it could be like a direct payment, it could be a directly commissioned service, but they do have full control depending on the situation. In the process of setting up the support package, I think of referring the young person to an advocate where it's necessary, because some young people, as we know, have they may not have the ability to make decisions for themselves. So I involve an advocate who can support them around those decision making and ensuring that they can, take part within the transition process. It also helps with limited like conflict or resistance from parents as well. So I thought I'd give you an example of our work. So let's talk about legislation and which guides transition. The legislative and policy framework. So my work is guided by two main legislation, two pieces of legislation. That's the Children and Family Act 2014 and the Care Act 2014. Okay, these two pieces of legislation provide the context in which transition work occurs. The Act highlights the requirement to prepare for adulthood young people with care and support needs. It means that the council, the local authority, must carry out, we have that duty, a transition assessment when it considers there is a significant benefit to the individual in doing so. This duty also applies to young people who are not receiving children's services. So under the Children and Family Act 2014, the Education, Health and Care Plan requirement for preparation for adulthood must begin at 14. That's the ideal age, because that's what the Care Act stipulates and the Children Act as well. So it must begin at 14. Between the age of 14 and 18, the transition social worker works under the disability service. And then we follow the children and young people service eligibility criteria. It means if a young person needs support when we complete the Care Act, when we complete the need assessment, children's services will be funding the support because they're still under the children and young people eligibility criteria. Moving forward, from the age of 18, the disability service adult social care eligibility policy will apply. Okay, so you can refer to that if you want a bit more information in the Care Act, so where you can have a lot more data around this. Young person, the young people being assessed for adult care and support post-18 will be considered under the Barking and Dagenham Adult Social Care Assessment and Eligibility Policy. Okay, so similarly, the adult policy will be applicable to those young persons over 18 in its entirety. Speaking of legislation, there are three main pieces of legislation that underpins my work, like I said before. Then we have the third one is the Mental Capacity Act 2005. I think I brushed a little bit on that, which introduced a type of advocacy provided by an independent mental capacity advocate. This gives some people, some young adults who lack capacity, a right to receive support from an IMCA, that's independent mental capacity advocate, from an IMCA in relation to important decisions about their care needs. Because we have, just to expand on that, we do have some young people that have no family members that could make decisions on their behalf. So therefore, we do refer them to an IMCA so that decision can be made fairly on their behalf. So we are going now to discuss what it takes to have a successful transition plan. Okay, so what's important to achieve a successful transition plan? Early intervention, okay, is key for a successful transition plan. using early intervention and an enablement approach to maximize choice and control, facilitating all young people to access universal services where needed, supporting those with more complex needs to access targeted or specialist services as and when required. Also, preventative services could be offered with the aim of delaying the development of needs or dependence on paid services. And yeah, the timing of the assessment, as I said before, is key. Yeah, assessment should be carried out at a time when it is of significant benefit to the young person and carer. We don't have to wait for them to be 18. They can be assessed when it's relevant. So it can be 16, it can be 14, it can be 17, it can be 18. Information sharing as well is key. Yeah? Joint work with parents and young person and other stakeholders as well. Because we need to acknowledge that transition is daunting for everybody, for parents especially, because they become emotional. Not only is daunting for the young person, but also for the parents, they become emotional. They have lots of worries because they don't know what's going to happen. It's the unknown that creates the anxiety. So therefore, it's good to start early and then to share information about what's available, how transition is going to happen, and what resources will be used, and so forth. Continuity of service is also key because children probably some of the young people I work with, we have a care package, they will have a service in place. So that's why I was talking about Cliff Edge and providing a mainstream service where transition starts early and then support is in place once the person turns 18. So continuity of service is good as well. So it's key in implementing a successful transition plan. And identifying SMART goals, setting and time frame and resources required to achieve personal outcome for the young person. Yeah, that's something as well to consider. Advocacy again. I think I mentioned advocacy. So under advocacy as well is very important because it enables the young person to be empowered, and he can take part of the process and is not alienated, and then we can really provide that person-centered approach, and then that will really focus on the person and what he wants really. So advocacy under the Care Act 2014, so the local authorities must arrange an independent advocate to facilitate the involvement of a person in the assessment process, in the preparation of the care and support plan, and in the review of the care plan if the person has substantial difficulty in being involved in the process and there is no one appropriate available to support and represent the person wishes. So moving forward, we're going to look at how to refer a young person to our services and for a transition. Tu peux partir, s'il te plaît. Merci. So we have so the referral. We have the intake team. Okay, the intake team is our first point of contact. So referral will be sent. We have a referral form that will be sent to the intake team. And the referral can be completed by anyone. It can be completed by the parents. It can be completed by the social worker, the children's social worker, and sometimes the school can complete it as well. Okay, so the referral is completed, but then sent to the intake team. Okay, the intake team we go through the triage and then send the referral to the disability service. And because I'm the specialist transition worker, the referral will be sent to me, and then I can start planning. And also, referral comes from, how can I say it? I have a list of young people because I was saying that I work with colleges like Trinity in Barking and Dagenham. So they do hold a list of young people that are transitioning into adulthood. So I do have a list, that I can refer to and start working with the young people. So my referral comes from the school as well, from transition work as well. So if once the threshold is met, transition assessment is completed, then support advice is provided to parents and to all involved. And from once the support started, we go and review the support plan to see what has been achieved, if the goals that we set the young person have been achieved, and then I end up making some necessary adjustments depending on the review. Okay, and that's it. So these are the email here. So to refer a young person for transition, so the referral will be completed. We have two emails because we have the health component and the social care component. Health, I mean by that the learning disability health services, specialist health services, and then social care. So we do work together so that we provide like a holistic support to the young person. So should the young person, if a young person is living with complex health needs and challenging behavior and some other form of disability, the referral is completed and sent to both social care and then health, so that health can be involved as well and provide some MDT input in managing behavior, while social care provide social care support. So I hope it made sense what I was explaining, and yeah, I'm ready for if you have any questions for me to answer. Thank you.
Thank you very much, Sarah, for that. That was brilliant. Thank you. And over to you, Abby. Questions for
There was a question about the email.
Can't
About the chat box.
Okay.
That's all we had. Lovely. Thank you. So now, in terms of our program, we're just bang on schedule actually. So we're going to have a comfort break, and obviously there's quite a lot of content that's been covered so far. So you know, in terms of having a think and just digesting that, but we'll have a 10-minute sort of eyes off screen break and take a stretch, or you know, get a cold drink, and then we'll resume back with the role of the community LD nurse in Havering for adults, which will touch on that more specifically. But and any questions that you think of, kind of come back afresh and put in the chat for us. But yeah, we'll have a quick 10-minute break, and please try and be back on time, because the next speaker will head forth at 2:45. So we want to try and stay on schedule, so just under 10 minutes. Thank you. Welcome back, everyone. I hope you can still hear me quite clearly. Just some thumbs up or hands up if you can. Hey, hello. Hi, Adam. Lovely. Thank you, guys. So we'll get cracking and get back into the programme. We've got Nicola Carter up next, who's our learning disability nurse from the community in Havering in particular. Hi, Nicola. Thank you. I'll hand over to you, and you can kind of share and introduce yourself.
Hi everyone. I just noticed if you see me looking up, I've got 3 screens in front of me, so I'm looking at all different things at the moment. So just bear with me. Welcome back. I don't know about anybody else, but I'm so hot. It's just terrible. I've got a fan on my feet, which I've actually turned off now. But okay, so I'm completely IT illiterate, but I will try my best to share the screen. So forgive me. Well, what am I meant to do? Is it this one? Do I click on the screen?
Yeah, right next
Oh,
to the
have I done it? Can you see that?
Yes.
Yay! Okay, so let's do this, if it works. If not, oh, here we go. There we go. So, hello and welcome. I think I've already done that bit, and I am Nicola Carter, and I'm one of the LD nurses from the Havering team. There's, in case people don't know, in terms of structures of teams, I'll talk about that a little bit later on, but just so you know, there's not hundreds of us in the team, even though we work across quite large areas, and also with lots of people demographically in each of the boroughs. There's myself and 5 other nurses within our team. It varies slightly across the other Nelft LD services. So I'm hoping that this works. Oh, no, that's not working. And that's not working. I'm stuck. I'm stuck on hello. Oh, there we go. Have I moved?
You have moved.
Yay. Okay, so I found this when I was doing my research. I'm always looking for stuff anyway. I love pictures. I love the pictures where people are drawing, but I can never find a really good one for LD nursing. But I found this, and I can sit here all day and talk about my job. I love it so much. I've been nursing for many years, and I actually still really enjoy it. And I think most of my LD colleagues, and actually nurses in general, most of us, we still have that passion. Even through the difficult times of COVID and lots of other things. So, and I think within LD and nursing generally, when you bring that passion, it supports the work that you do. So just sort of a little bit of a kind of a whiz round. We, as a learning disability nurse, we advocate, we teach. I will go into a little bit more detail about kind of things that we do. And we are a specialist. And my next slide, I know I probably shouldn't use so many exclamation marks, but people are surprised that we are actually real nurses when they ask, and that we have actually gone on and trained and specialised within this area. We work person-centred, and that's come across a whole load through the presentations that were completed before myself. And holistic, I think everyone's sort of mentioned that, and that's really important. It sometimes sounds a bit of a fancy word, but you know, it's about looking at the whole of the person. It's, you know, so we say we're nurses, but we you know, obviously we look at the physical health, but we're looking at the mental health. We're working in conjunction with our colleagues, thinking about the financial implications on someone's health and their mental health, looking at their environmental, social situation. So we don't just come in and do our blood pressures and pulse oximeter and that's it, we're done and off we go. So it's quite it is a very specialised focused area. Communication is key in our job, not just communicating with other services involved, but obviously with the person themselves, knowing that person and how they communicate and supporting them. Solving problems, oh my gosh, I'm sure I can see Tim and Abby and Laura just going, yeah, this is what we do most of our days. We're thinking outside of the box. How can we work with this person to achieve whatever that action, the goal is from the identified area that we've now, forgive me, I thought this said work false multiplier when I looked at it on a small screen, and then I realised it said multiplier. So for me, I thought it was just that we not that we flew around in helicopters, but we basically work across with lots of other people. And I'm not too sure about what this is, but we link in with lots of other people, and we're always saying, well, what about this person? What could their role be in? Maybe we need to research. Maybe there's someone else that can do this, and we can work alongside. I think that's what it is, but I definitely cannot fly a helicopter, just in case anyone asks. Right, I'm now going to attempt to move. So I've kind of gone over this, so I won't bore you to tears. But we are specialist nurses. We have trained. I mean, I'm a bit of a dinosaur. So I did the diploma, and so initially I sort of trained in all different areas of nursing, and then went on to specialise in LD nursing. So it was then 18 months of a 3-year course was focused on nursing. And then I went on to do my degree at a later stage, whereas you'll see nurses now, they'll go in with their BScs, their degrees. So we have those degrees. We are educated and we are real nurses. And I know I go on about this, but this is not for everybody that's on the webinar, but this is about that, you know, we are evidence-based practitioners. What we do, we work together with other colleagues, clinicians, services, and, you know, we do know what we're talking about, and from experience, and obviously our training as well. And I've put this because I thought other people might have mentioned this beforehand, but I'm not sure if they have. I missed the first little bit. I'm so sorry. We do, LD nurses do work across the board. As you can see, obviously you've got Kim and Abby, and we work in private sectors, hospices, work in children's services and social care. And I put education because that's quite close to my heart, in training and educating, not just nurses coming into LD, but actually general nurses or adult nurses and other clinicians about what LD is and what it isn't, and how our teams work, because we're very specialised. Okay, so within NELFT, I'm just going to bring these up. So we've got 4 community LD teams, and I just wanted to go back to, I know someone asked about referral to Havering. I will send this to you, Laura. There's a link on the NELFT website, which people can access all of the LD teams, a little blurb about them, but also the address, the phone numbers, and how to, and the referral form. And there is one for Havering on there. So, but I will send that through because I think you're sending out a goodie bag, aren't you, Laura? Anyway. So, okay, so we have Havering, that's where I'm from. Redbridge, that Dennis spoke about his role. There's Waltham Forest, Barking and Dagenham, and we have an inpatient unit called Moor Ward at Goodmayes. Just a little bit about that. That is specifically for people with LD who are presenting with a mental health crisis. Alongside that, they might also be presenting with behavioural issues, but you know, the premise is somebody's not admitted to an inpatient psychiatric unit just because of their behaviour. And you'll see when I talk a little bit more about our role in terms of the teams and LD nursing, how we support people with behavioural concerns. What else was I going to say about that? I think that's it on that one. So let me move on. Who is actually in the team? So, oh, are you going to be working? Yes. So I've said a little bit about me. Now, some of the people who are listening might have already had experience of working alongside these clinicians, because you'll see these clinicians working within children's services also, and very much doing very similar work as you will do when you come over into the adult team. As explained, we are integrated team, so we work alongside our social care colleagues within the boroughs that we work for. So I'm just moving these up, sorry. So we've got art therapy that sits under psychology, as does behaviour specialists. So if a referral comes in, we discuss that in our team meeting every week, and there's a head of each discipline, and we discuss the referral. and who really should be involved. And it might be a joint visit, it might be someone individual from one discipline goes out and then feeds back at the meeting. It's very coordinated, and we ensure that we're picking up lots of information from other disciplines to get advice. I'm just a little bit, if not no social workers we talked about. So community support workers. So within the nursing team, we have a lady by the name of Jill Balch, and she's kind of like a healthcare assistant that works alongside the nurses, very experienced, supports with taking blood, and does health facilitation, almost does exactly what we do, but doesn't actually complete nursing assessments and doesn't identify recommendation. We've also got therapy assistants, and we have one therapy assistant who works across both physio and occupational therapy. And also we've got social work assistants as well, or the care assessors, sorry, that I should change that, that's incorrect. Again, very experienced, almost do exactly the same as a social worker, but obviously there's differences in the assessments that they can do and carry out. There's one person I've missed off. Again, this is an older slide, I must update it. But we've now also got a specialist learning disability, a pharmacist who's working across all the NELF teams. And she's been really key in the STOMP work, which I'll talk a little bit later on. But also very recently, we've been doing quite a lot of work on the COVID vaccinations, supporting, she's obviously been providing us support on training in administering the vaccine, but she also goes out and has been administering the vaccine, because obviously our priority was get as many people supported to understand what the vaccine was about, provide support in informed consent or doing mental capacity assessments, and then obviously administering those vaccines. So just moving on. So what happens when someone's referred to team? So I spoke a little bit about it. I apologise if I'm talking really fast. I'm just aware I talk a lot and I digress. So I'm trying to make sure that I get done in the time. So we've got, very much like Dennis had mentioned, we have a referral criteria. It's much the same in terms of for it's an adult service, so 18 onwards, but we do start looking at people coming in from 17 and a half. Obviously, if we're noted, a lot of the children's teams do refer into us a little bit earlier, so we can review that assessment, but it will be put on hold. We don't actually do any work at that particular time, that directed work, but we're identifying that person's needs, because obviously planning is really key. And again, just to answer someone else's question that came up in the chat, we don't actually have a designated LD nurse for the transition role. So from a learning disability nursing point, it would be great if we did. It would support lots of issues around things getting missed. We could do some, maybe identify any issues that need to be picked up, or maybe start thinking about what work's needed for that person. So that is very different, and each team is very different. I can't speak on behalf of the other teams, so do forgive me. And most of the teams are slightly different in their in how they process their referrals, but it's much the same. Obviously, the referral comes in. We discuss those as a team. We identify the most appropriate clinician. We ensure that they meet the criteria. And we've obviously, I've got 18 years with an LD, evidence is required. And I know Dennis touched on this quite a bit, actually, just saying he actually put a good list up about what evidence we're looking for. And just to reiterate what he said, we're not looking, it don't generally just look at IQ. We're not looking, you know, you hear people, oh, 70 and below IQ, but we're gone are those days. Are we looking specifically at the IQ? Our main 3 areas is that we're looking at there's an impairment of intellectual functioning, social adaptive functioning, impairment of social adaptive functioning, sorry, and we're looking at age of onset. So anything that's occurred prior to the age of 18 in terms of impacting on that person's intellectual functioning and social adaptive functioning. If we're not sure, we will do a screening, and again, I think that's similar. I know it's similar to the same as Redbridge, and probably across the other teams again, but again, don't quote me. But we will meet with that person and we will request further information, and we will do some other sort of assessments just to check whether this person is eligible for learning disability services. Okay, and I mentioned about the referral link that I can send you, Laura, for NELFT, and that will cover all of the teams. So I found this again on my hunt around, and I do like to add new things in, but I really like this. We talk about equity of services a lot as nurses, and generally within LD services, not just health. And, you know, where we want to really get is obviously the justice, but I see the LD role in, you know, sometimes we're shown the reality and then we want to move towards equality, but you know there's still more work that needs to be done to actually get to equity. And I suppose I'm seeing the role of the LD nurse within this in helping support others to shuffle those boxes around, and maybe if we get to justice, knock down that fence as well. So that was just more of a little kind of an interesting picture. Okay, so our overarching role is support people to make informed decisions about their healthcare. And I know the previous speaker talked about mental capacity assessments and checking people's capacity. And again, this is quite a large role of ours. Again, not we work with others about people making decisions about their healthcare, but if we assess that they are unable to do that, we work on a best interest basis with other clinicians and still that person and their family and their carers who are also pivotal in that journey. Support access to generic health services. So when we say generic, it's what you and I access on a daily basis. So again, my colleague Dennis from the Redbridge team, he talked about reasonable adjustments and things that we can do to help that person access that service. Because we know there are some issues that, you know, you and I, you know, we just get on with our day, it doesn't impact us. But as the people we work with have got varying levels of needs, we're able to support them identify the issues that might be impacting or impeding on them accessing that service. Improving or monitoring a person's physical and mental health. Again, we talk about holistic support. Reducing the barriers to support access to as independent life as possible. Although we talk about physical and mental health, it's about a person just fulfilling their desires and their wants, just to live the life that they choose as best as we can in terms of our services. And as I mentioned, I do like the navigating their own health journey, because I don't know about anyone else, sometimes accessing services, not just NHS but other services, can be quite a choppy, like sailing on the sea, isn't it? So it's kind of sort of helping that person get through that, because even we struggle sometimes when it might be issues around written skills, verbal communication, and that's where the advocacy comes into this, and health facilitation. So health facilitation and health advocacy. Am I all right for time? I know I'm talking lots and lots. So forgive me again, I was trying really hard to be really clever and do this amazing pictorial representation of the nursing process. So this is really close to my heart. This is how we work, it's how all nurses work. We start off basically, I'm sorry, I've got a picture in front of me and I can't read that. So we start off with meeting the person, and I've used as many pictures as I can in this where somebody is sitting next to the person. So the journey is together. I like these pictures. It's about, you know, this has been the issue with COVID, where we've not been able to go and be with people and ask them these sometimes very personal questions. And sometimes with families that we work with, they've repeated this story over and over and over again. So as nurses, we try, in LD nursing, we try and recognise that maybe there's some information that we can pull off some obviously current assessments. So we're trying to think about how we support that person and their family and carers, and not to make this assessment process as easy as possible. So we will try to meet with the individual and the family or the carers or the most important people around them, and that could be anybody. after we've sort of made that arrangement, we will then complete our nursing assessment, which will be, again, we use the word holistic assessment. Within our nursing assessment, we are asking questions about, you know, what are your daily activities? You know, are you going to day service? Are you in employment? You know, asking them about their mental health, their physical health, and what things do they enjoy? Do they help around the house? You know, we're talking about everything. We're not just doing their weight, height, and BMI. After that, we then make recommendations. So at the end of our nursing assessment, which actually, you know, can take quite a while, we then make recommendations how and who can provide support. It's different for everybody. I could be here all day telling you about all the different actions, recommendations from all the different nursing assessments I've done over the years. But our main actions, our core actions, are that we can that we complete. Well, I say health action plan. The GPs do health action plans, but we also do them. Well, we in Havering, we identify what is it that we've identified from our nursing assessment, and who else is going to be involved, taking the lead, who's going to support them. This can link in also with the annual health check that the GPs do. We will make sure that that person's got a hospital passport, and also that there's a care plan to reflect whatever that particular recommendation is. So, and that will be quite detailed and individualised for that person. And then we move on, that we'll link in with the services who work alongside the person. We can do one-to-one work, we might refer to group, we may be running, and then, oopsie, I messed that up. And then we evaluate the work. So we look at what have we done. And in fact, actually, for nursing, we're evaluating all the time. We're thinking, is this the right way, what we're doing? Should we slightly change this? Are we the right person to be involved with this? Should we be working with another colleague on this work? You know, actually, we're doing really well. Let's move on to something else. So, and then we don't keep people on forever. I remember working many years back, a health visitor asked me whether I would be working with this person for life. Obviously, I had to explain that that's not how we work. There's not enough of us anyway. But clinicians, especially clinicians, don't work like that. We do have to identify a piece of work in liaison with the family, the person, the carers, and we will close the case. But the person is always still open to the LD service. Okay. So I think I'm talking, I don't know the time, sorry. So I've already mentioned the individual work, the group work, supporting others, just some examples. We work with drug, alcohol, diabetes service, just an example, work with lots of other people. The main thing is when you meet us, we will listen, support, act, and the nursing assessment, and we talked about generic health services. Mentioned about, I think we talked about annual health checks. Dennis spoke a lot about that, so I won't spend too much time. And we talked about what does that look like in terms of the assessments that the GPs do. And we try, in our role as the LD nurses in a community, we're linked into each kind of GP surgery in terms of supporting them. So if they've got any concerns when they're working with someone, they can contact us, they can phone us, they can refer in, we can go out and visit, we can provide lots of support for GPs. If there's anyone on the webinar that's really concerned that they haven't had an annual health check, and they're really struggling, maybe they've been to it and maybe that person's not engaged very well, or you reach a stumbling block with the blood test, which I'll just move on to in a moment. And, you know, contact your local LD team. You know, that I'm sure the LD nurse will provide support. It might mean a referral and some direct work, but please do contact us. If you don't take anything else away, because I know I'm talking a lot, just, you know, always know who your local LD team is for adult services, LD services, and give us a call. So just very quickly, some of the work we do. This is a very focused piece of work we do. We get a lot of referrals in, and we know a lot of young people come in to our service referred in, and they've never had a blood test, or maybe they had a blood test when they were 6 or 5, 6, 7, and while they're children, they're able to be legally be supported and held to have the blood test. And then what happens when we have service users come in when they're 18? You know, under the legal framework, you cannot restrain someone to have a blood test. So then we work together with that person. We identify what the issues are. Again, everybody's all individual. It's all very different. And At the moment, I'm working with my colleague Jason, who's another LD nurse, and we're looking at innovating a desensitisation sort of workshop. So basically, it'll be Jason and I talking through and recording ourselves and sending that out to families, carers, on how to start supporting someone to desensitise them. And the why we're doing this is because we're getting so many referrals in, and we've identified that we know if you start early with this kind of work, that actually, and in their own home environment with people that they know and care for. And I'm not talking about getting needles out. I'm talking about, I can talk more another time if people are interested on blood test desensitisation. It's about exposing that person to kind of touch and the feeling of the tourniquet on their arm. Sometimes these are issues that we know a lot of people are not comfortable with. Like I said, I could talk all day about this. So we're looking at ways that we can support people through this. It's the graded exposure and hierarchy tools. I was going to bring it up, but I knew I'd talked too much now, and I'm well over my time, I know. So from that, another quick example, we do health promotion, we do group work, healthy living groups, promoting a healthy lifestyle. We do individualised stuff, so sexual knowledge assessments, which just to point out, we're actually reviewing at the moment our assessment to ensure it's up to date and evidence-based. We do a lot of men and women wellbeing groups, and specifically this ties in with the Learning Disability Mortality Review and the NHS plan about ensuring people are having the equal, going back to the equity, the access to cancer screening, bowel screening, breast screening, testicular screening. These are our biggies that we try and ensure people are getting support through that. Okay, and okay, just very quickly. So I'm talking from I'm currently working with our LD pharmacists doing the STOMP, which is stopping the over medication of people with learning disabilities. And in a nutshell, we find a lot of people with LD are coming into our service. They're on medication for behaviour, which is actually for mental health issues. So we're working with those people and their families and carers and wider colleagues, clinicians, on reducing the amount of medication that person's on and trying to put in other non-pharmacological, I said it, I was waiting for myself to trip over that, interventions, and that is the positive behaviour support. Again, there's lots of information on this. I think I've put some links in some webinars that we've done on PBS and I think STOMP as well, if family carers want to know a little bit more about that. And also, this was an outcome of the leader was to start doing. So I think Dennis is as well, train the trainer in Restore. So this is supporting families and carers to increase their skills and knowledge and how to recognise a very subtle deterioration of a person, their physical health deterioration. This came up more in the COVID pandemic, where with people with learning disabilities, signs were being missed in terms of their oxygen saturation levels and deterioration in general. So again, I can talk and offer training if people are interested in that. Now, I think you've already got those, but like I said, they might not be up to date fully because I was trying to get these from other people. So I'll send the NELF link and it will have all of the NELF LD teams. I've added some resources as well that can go out in the goodie bag. And these are we've done load of NELF webinars during COVID. Lots of stuff on there about communicating pain, hospital passports, stuff like that. And also, this is the Restore Mini 2 training. Sorry, not the training. It's the actual Restore Mini 2 leaflet that you can send out also. And if you get time later on in your day, have a look at this. This is all about learning disability nursing, but learning disability as well, and how we're working together to keep LD at the top of everyone's agenda, the government, and trying to increase number of LD nurses, getting LD services really focused and specialised for our service users. And that is the end. Ta-da! I've just got to figure out how to end it. Oh, that's it. And how do I transition out?
Just press stop sharing and X your screen.
Is it, yeah. Oh, there we go.
There you go. Thank you so much, Nicola. We lost you slightly just right at the end, but it was fine. I think you was just you just said the end. To be
I was
fair.
just rattling off about nothing.
No, it's been really, really helpful, and actually just consolidated and touched on a few of the things that Dennis did in a bit more detail. So thank you. Any questions? Over to Abby. I think we had 1 or 2 questions in the chat.
Okay, I can see one. So is that, do LD nurses carry out continuing healthcare assessments? Okay, so in Havering we have separate CHC nurses, but if we're involved with someone, so if I'm allocated to a client, I will attend those, and I will support the homes and the individuals with gathering the evidence up in terms of if they've got behaviours, so behaviour forms. So we will provide support, but we won't do them. And I know a lot of our CHC nurse assessors, if they need support, they will contact our team as well. So what was the other part of that? Sorry, nurse. Yeah, I mean, all I can suggest to people if they're going through a CHC assessment is that they ensure they've got up-to-date reports from all of the clinicians, whether they're under Great Ormond Street or whomever, all the up-to-date reports, any monitoring forms, and CHC want very detailed monitoring forms. So if it's behaviour monitoring forms, if it's fluid input-output charts, if it's I'm trying to think what other monitoring forms, if you're looking at eating and drinking, stuff like that. What else is that? Oh, thank you for the thank yous.
Thank you very much. I'm going to move swiftly on to our next speaker. We've got Masuma, who is going to talk a little bit about positive behavioural support, specifically for learning disability and autism, or autism, from NELF. But I'll let you introduce yourself, Masuma. You're good to go. Thank you.
Hi everyone, I'm Masuma Chowdhury. I'm the Learning Disabilities and Autism Project Manager, and I should have also Rachel Penny on the call as well.
Hi. Sorry, Laura, you stuck with me as well. We're doing a double act today.
Thank you, Rachel, for joining as well. So thank you.
No worries. So I'm the Learning Disability and Autism Strategic Lead for North East London CCG. So I cover all 7, which includes Barking, Dagenham, Havering and Redbridge. And as Masuma said, she is one of my right-hand people. She's the project manager in our team. So we, in a nutshell, have responsibility for making sure that the right strategies are in place across healthcare in North East London to make sure that people with learning disabilities and autism of all ages are accessing the right support at the right time. Now, as you can imagine, that's a massive portfolio, and I'm certainly not going to talk about all of it today. We've been asked specifically to talk to everybody about positive behaviour support, or what might be called behaviours that challenge the service, and what is available if you are supporting somebody who may exhibit behaviours in that line. It is quite an emotive topic, I will be honest with you, and it looks very, very different for different people. So we don't have very long. We're going to just sort of give you a bit of a whistle stop around it, but just to acknowledge that, do appreciate that this can look very, very different for different people, and we're happy to discuss anything individually offline if this doesn't quite cover off what you need. But I'm going to start by handing over to Masuma, who kind of project manages the PBS service within the CCG, and she's just going to talk a little bit about what PBS is and what we commission.
Thank you, Rachel. So positive behaviour support. What is positive behaviour support, also known as PBS? So it's a person-centred framework for providing long-term support with people who have a learning disability and or autism, who have or may be at risk of developing behaviours that challenge. It's a blend of person-centred values and behavioural science, and uses evidence to inform decision-making. PBS approaches are based on a set of overarching values. These values include the commitment to providing support that promotes inclusion, choice, participation, and equality of opportunity. So all behaviours have a meaning, and positive behaviour support aims to understand what behaviours that challenge tell us, so that person's need can be met in better ways. The way the person is supported often has to change to achieve this, and this needs to be regularly reviewed by all the people involved. And the people involved are often multidisciplinary or be various professionals. So when might you need positive behavior support when it comes to transition? So when a young person or a child is going through transition, they might display changes in their behavior or challenging behavior or increased challenging behavior. This is where you can access positive behavior support and learn the meaning behind that behavior. PBS is an approach that puts the person at the center to make the system work for that person. It's giving the right support at the right time so people can thrive to their potential. You might ask, how do we know PBS works? There's strong evidence that PBS is effective in producing positive outcomes, for example, increasing the person's skills and positive life opportunities. The approach is based on psychological theory using process of applied behavior analysis. It's been developing within a variety of settings for many years and has strong practice base. So PBS is being used successfully. And overall, PBS is most successful if everyone supporting that person uses it. So this is when the person's family, care provider, school, services all agree to use PBS. They should follow a shared PBS plan, which we'll talk about a little bit more later on, and communicate regularly about the changes in the person's plan. It makes sure that the person is supported consistently throughout the day and week in different settings. Sometimes barriers can occur to making PBS happen, and this is most likely when a service or the person's family aren't aware of PBS or are reluctant to make a change. You may want to use different approaches, discuss this, looking to PBS more, what it means, what it involves. I'm just going to go into the next slide. So there are core elements of PBS, and there's quite a few. I'm not going to go into too many, but it's based around values, theory, processes. And the components have been recommended in a number of policy documents and professional guidelines, including the NICE guidelines for challenging behavior. And what we offer is PBS training, positive behavior training, and it's open to parents and carers as well as professionals. So this call is great. I can see a huge number of people here, and it's great that I get to talk about this because everyone here potentially could go on this training. And what we're offering, we're working with iSupport Behavior, who will be delivering this training. And the level 1 PBS training for parents and carers who will attend this, it provides clear definition of PBS and describes a model of understanding behaviors of concern. So when you attend these webinars, so we're hoping that this will be a blended approach. So it will be a bit of online learning with the possibility of face-to-face sessions, depending on government guidance and how we proceed forward. You'll understand the values and definitions of PBS, understand the importance of person-centered approaches and quality of life, understand the role of supportive and capable environments, and understand behavior and its function. So you might ask, what is the meaning of this behavior? Why is this behavior happening? How can I manage this behavior? What measures can I put in place to support the young person to manage that behavior? So attending this with behavioral specialist or a psychologist who will run the sessions, you can go through all of this, and in the end you receive a sort of certificate which allows you to then use this in your day-to-day lives at home. We also have bespoke one-to-one sessions, and we ran this last year and it was really, really popular. And this is a one-to-one session. This could be attended either by the parents or parent or a family member, parent and carer, or professionals. And it's a 1-hour session with a behavior analyst. And it aims to provide an opportunity to seek advice and guidance around specific situations relating to someone you might be supporting who has learning disabilities and or autism and is displaying challenging behavior. So all in all, it's a session where you get to attend on your own with somebody else who supports the young person, and you can ask all the questions that you're concerned about, whether it's to do with the behavior or whether it's to do with any other concerns that you have, and they'll talk through the sort of activities and day-to-day things that occur to pin down what is occurring that relates to that behavior. So functional behavior assessments. A functional behavior assessment identifies where, when, and the likely reasons why a behavior of concern happens. This information is then used to inform a behavior support plan, which includes strategies to address the reasons why the behavior is occurring. It's basically a summary of the FBA process and the assessment findings. So how the core part of the assessment in PBS is to understand why the behavior that challenges happens, how the behavior has been learned, and how it's maintained. Once the reason for the behavior has been identified, a PBS plan is co-produced and followed by everyone involved in supporting the person. So the steps of a functional behavior assessment, in short, is something I call DASH. So D stands for describe, which is a clear description of the behaviors and is agreed by everyone, noting when and where it happens and its impact. The second part is ask. So questionnaires and rating scales are used to find out more about the behavior and the situations in which it is most likely to occur. People who know the individual best might be asked to start to record information about the behavior if this isn't in place already. So it might be something like an ABC chart, which is where you write down the time, the day, the behavior that occurred, what happened just before the behavior, which is called antecedent, and then how often that occurs, to sort of understand the pattern in the behavior and how often it occurs, whether it's something related, whether there's a trigger for that behavior. S, which is C, so where possible and safe to do so, direct observation is carried out to gain a better picture of the individual's environment and how they spend their time. And lastly, it's the hypothesis. So all the information gathered help develop a hypothesis, an opinion about why we think the behavior is occurring and what it means to the individual. Once the assessment has been completed, a report will be created and shared with everyone who has been involved, and this could be all the professionals involved with the individual. The outcomes are set out in a report, and it's used to put together a PBS plan. So PBS plan, so behavior support plan, it is also known as a PBS plan or individual teaching plan, individual education plan. It's an essential component of PBS. Behavior support plans can be presented in different ways depending on who they are written by and who is going to use them. It sets out the support required to help someone achieve a good quality of life. And it should be developed in partnership with the person and their family. PBS is most effective when individuals are supported by people who have a good relationship and rapport with them and who understand PBS. The plan promotes proactive and preventative strategies and includes teaching new skills. This might include strategies to avert crisis and keep people safe. So a good behavior support plan should include people, so family, friends, work colleagues, activities. So this could be at home, at school, leisure or hobbies, objects, so personal possessions, toys, and places, indoors, outdoors, if it's a busy room, quiet room, specific room, and venues. So if you need help with someone who's displaying challenging behavior, firstly, you need to check for any health problems, because sometimes there could be underlying health conditions that's related to that challenging behavior or that specific behavior. So for example, undiagnosed medical needs, for example, an ear infection. So a child might be acting out and pulling on their ear or sort of banging their head against something. And that could be because they can't communicate that it's about pain and they're in pain. So trying to get as much information as possible, that's the first step. And then the second one might be to speak to either the school or care provider or anywhere else to find out what is actually going on, if that behavior is repeating or not. But overall, the training that we offer, the level 1 PBS training for parents and carers and professionals, is accessible for Barking and Dagenham, Havering, Redbridge and Waltham Forest. And there's information later on in the slide pack with how you can access this training. We will have a training plan in place and dates. We're working on that currently, as we've just commissioned this again for this year. But it's highly recommended if you want to understand more about challenging behavior and why the behavior occurs, and especially when you're going through that transition phase where it could be difficult for the child or young person who's going through that as they're aging, their emotions changing, their hormonal changes, that could display different behavior that you haven't seen before or increased challenging behavior. And this is where, when you access this training as well as the one-to-one support, you can sort of pin down on how you can manage that better. Sorry, I think I've talked so much non-stop now. Next. Oh, so I'm going to pass. Does anybody have any questions for me yet?
I think we're doing them at the end, so it's fine.
Okay.
I'm going to have to try and wrap up really quickly because we're so short on time. So I really apologise if I sound like I'm gabbling through a little bit. I just wanted to talk a little bit about referring into these sort of services, because first things first, if you're under the care of a team who already provides a behavioural resource, that should be your first port of call. So Nicola, I think, was already talking earlier about the fact that if you're under a CLDT, there's a behavioural team there that you can access. The resources commissioned by the CCG are open to absolutely everybody and anybody who works with somebody with learning disabilities or autism. It doesn't have to be a parent. If you've got support workers coming in, that's absolutely fine. They can access it as well. The main reason we commissioned it is because we found that there were a lot of people who were struggling a bit with gatekeeping. So if they weren't able to access this kind of support through their routinely available services, if they couldn't get it through CAMHS, if they're adults and they're not under the CLDT, they really sort of struggle sometimes to get that behavioural resource, particularly if you've got a young person turning 18 who's got autism only, which is probably the biggest gap that we've had. So what I would say is that if you do have access to this kind of support through your kind of allocated community team, whoever that may be, or your school or whoever you're working with, always go there first as your first port of call. But if you need a top up of support, or if you don't have a readily available community resource to provide that support, this is probably sort of more geared to you and the sort of things that you need. We did just sort of mention STOMP here as well, just because in terms of behaviours that challenge, over medication is a massive issue. Use of medication is completely appropriate if it's well balanced and if it's promoting that person's quality of life. But we do often see people that are given medication as a first port of call to manage behaviour. And as Nicola said, we do have a specialist pharmacist who is able to work on that if you're sort of interested in looking at bringing that medication down. If you could go on the next slide for me, Nsima, because I think you've got them. We do have a specialist autism service as well for young people as they turn 18 and over. Sometimes, again, that is a bit of a cliff edge. If your young person has an autism-only diagnosis. At the moment, this service is quite limited, and it is mostly for people that need really enhanced support, and they can offer enhanced psychology, sensory assessments, and support around social skills. We are looking at expanding the offer for people with autism. We do have quite a significant ring-fenced budget this year, and some people may have seen the National Autism Strategy came out yesterday, so we've certainly got a template to be working towards. So we will be trying to expand that offer, but we do have this available as people are turning over 18 if they do need that resource. If I could have the next slide. Okay, so just really briefly, I just wanted to talk a little bit about crisis, which is something that is often experienced with young people that challenge behaviour, have behaviours that challenge. Again, not the nicest of topics, but I'd rather people know what's available and never need to use it than hit crisis point and not know what's out there. So every borough does have what's called a dynamic support register. which is a list, I suppose, of people with learning disabilities and autism that need enhanced support. It was originally introduced to stop people going into crisis and being admitted into mental health hospitals. But in North East London, we're trying to sort of move away from using it as crisis management. And it's also for people who might need enhanced support to make sure they don't get on that pathway long term. That means they could end up in crisis if we don't act early. So we have dynamic support registers locally, and those are monitored by an MDT on a monthly basis to make sure that those individuals are getting that enhanced support they need. And if you could go on to the next slide for me, Masuma, the kind of next step up from that is care education and treatment reviews. So again, if you're working with a young person who may need that really enhanced support to make sure that they are being well and safely managed in the community, we can offer care treatment reviews. They are a full day long review. It's centred around the person and their family, and then everybody who supports that young person is invited to attend. It's chaired by the CCG, and we also have 2 independent people from NHS England who join us, who are there to kind of give us new ideas, but also challenge us a bit if perhaps we're not putting in everything that we should be. It's not kind of open to absolutely everybody, but it is an avenue for people if you're thinking, actually, my young person isn't getting the support that they need and this could potentially end up in a crisis situation. This is kind of there for you to make sure that their care, education and treatment is properly reviewed, and there is an action plan, if you go on to the next page for me, Masuma, that comes out of that CTR for agencies to follow. So I'm going to end there just because I know that we're pushing the agenda a lot. So apologies that we've gabbled through quite a lot quite quickly. And if there are any questions, if I have a couple of minutes, I don't know.
Thank you so much. Thank you, Masuma and Rachel. Really, really helpful. Really good. We have got a few questions. I think just 1 or 2. You answered some during your segment, actually. But the other thing that was just mentioned was, I think it's more of a kind of comment. With autism, if you've heard about the iceberg, we should look at the underlying causes of behaviour, not just focus on controlling the behaviour, which you touched on. And that's why Redbridge is not focusing on the ABA approach, but evidence-based speech therapy and OT support. So I'm not sure if that, I think that's more of a comment. And then Liz did mention, she said, how do we ensure that we don't duplicate our resources for PBS, school and parent, because school and parents have multiple services in Redbridge which can offer behaviour management for children and young people. Yeah. But I think you touched on that when you said, obviously, if you're already under,
if you've got it, that's your first port of call. This is either an additional layer or it's for people that can't routinely access it. So hopefully I've covered that more or less, but it's a very good point.
Yeah. And then the first question we did have from Karen, she said, how will parents be told about the training and one-to-one sessions?
Sure. So we, as I said, are the North East London programme team, so we cover 7 boroughs. So we meet with our borough leads, both from health and social care, and we do rely on them to disseminate that information sort of through their local groups, their carers forums, making sure that our sort of frontline teams who are working with people know about it as well. So we do rely on our local borough contacts to do that. But if anyone's got any particular ideas about where we could direct them to go, we're very, very happy to do that.
Brilliant, thank you. And just the last question that's quickly come in from Lillian. It says, hi Rachel, how do we refer an adult who has autism but may have been missed in the transition to adults, as they didn't have care and support needs, but I guess now they need skills to manage their behaviour?
Thank you for that. That is an excellent question. It's a really excellent question because that is really, really common. And I think the point that we're making, that there is a lot of really good local resource currently to support parents, but we do have a lot of parents who missed the boat. And that's one of the reasons why these resources are here. If there wasn't a huge amount when your young person was going through transition, we're still very much there to offer those skills and support for you. So when the pack comes out after the session, the referral address is on the end of the slides. So I think it's nell.lda@nhs.net, but it's on the slides. So if you want that training, please do email in. Or if you want the bespoke sessions, which I probably would suggest, if you've had the training somewhere else and you're pretty clear on your facts, you may not need the formal training, but those one-to-one sessions where you can have kind of conversations about your personal individual situation and the person you support, you may find that really beneficial. And I know during the pandemic where people were cut off from a lot, it was particularly useful. So I think Masuma's popped the address in the chat, but we will share the slides. Drop us an email and we can get you booked in.
Perfect. Thank you so much.
Do you mind if I just jump in with a quick question for Rachel? Sorry. Thank you, Rachel. That was really interesting. I just wanted to ask, you mentioned about services for young people with autism. And you mentioned at the moment they're fairly limited. I was just wondering if, and sorry if this is a tricky question, but I was just wondering if there are plans or talks to expand that further. It's something that we come across quite regularly is that services for people with learning disabilities, like you say, there are fairly comprehensive community LD teams in place, but for some of the people with autism that we support that don't have learning disabilities, there's less available for them in adulthood. And I just wondered whether there were plans for that.
There are some plans. I'm not gonna lie to you, Tim. There are plans. I don't think those plans are fully worked up yet because the response to our lack of services for autism is being addressed on a national scale. Hence why we've had the new strategy come out yesterday. So I think there's going to be a big revamp on the horizon about the kind of issues you say about where does somebody with autism only go if they need social care input, that wider question. The immediate plans for things that we have to do is, one, we need to sort out the autism diagnosis backlog for adults and children, and we need to sort out pre and post diagnostic support. So if you've got somebody on the wait list and that wait list is long, it's not enough just to leave somebody there waiting without any support while they're waiting for that diagnosis. But we also need to be offering that pre-diagnosis support. What does that diagnosis mean for you? What support can we put in place to come to terms with it? So that's the immediate kind of short-term resource that we will be putting in sometime this year. Longer term, I think there will need to be a more in-depth look about how we work with social care colleagues to look at the kind of health and social care availability for adults with autism. So sorry, that's not a brilliant to the point answer. It's kind of a two-stage answer. But we do have some immediate plans, and longer term, the kind of this wider social care thing will, I think, be addressed by the national strategy. But I haven't read it in full yet. It only came out yesterday, so I'm really sorry.
That's fine. That's really reassuring. Thank you.
Thank you. So we'll now have a quick kind of off-screen break. We should be able to get back on track with time, so not to worry. I want to encourage everyone to still kind of stay with us because our last two segments will be really important. We'll be touching on consent and decision making and helping young people as they reach that transition age and into adulthood, how that changes. And for a lot of parents, this is where we get a lot of questions. So that will be straight up after the break. So we'll have a quick I say 10 minutes, under 10 minutes. We'll start back again at 10:02, please. And the next session will be why is consent and decision making important? And that will be a really interesting session, I believe. So see you guys shortly. Thank you. Welcome back, everyone. Hope we've still got most people with us. So as I mentioned before the break, and if anyone's kind of joined in between, we're now at the stage of the program where we'll be talking about why consent and decision making is important, especially for our young people entering into that transition age, sort of specifically 16 to 18. And for this section, we've actually created a video for you guys by myself and very kindly Val Marlin, who is our safeguarding adult advisor for MCA and Dolls in the Trust. So I'll hand over to Charlene, who will kind of, share the content of that. And please feel free to, if there's any questions, we will be able to hopefully answer them in this session. But if not, we'll be able to get a response to you guys. Val has kindly offered, she's not here in person, but kindly offered that any sort of questions that can't be answered here, she'll be able to follow up on and give advice. Yeah, enjoy.
Can everyone see my screen?
Yes, we can.
So today we're going to discuss consent and decision making in relation to transition, especially with young people of a particular age from 16 and above. I'll first start by introducing myself. I'm Laura Adiefa. I'm the Learning Disability and Autism Nurse for BHRUT, covering both sites, and I have with me.
I'm Val Marling. I'm an Adult Safeguarding Advisor and I specialise in the Mental Capacity Act and Deprivation of Liberty Safeguards, and I cover both sites too.
So I thought I'd first start by defining what the transition age is. So according to the NICE guidelines, transition should start from children's services to adulthood from the age of 14 to 16. And I guess the important thing is with consent and decision making, it's really important for families as well as the young person. Parents often feel that they've made all the decisions about their young person's life for so long because they've got parental responsibility. And I guess the first question would be, how does this differ when that young person becomes 16 in relation to their decision making and consent?
Okay, well the reason that it changes is because the Mental Capacity Act comes into force, if you like, at age 16. So whereas you said, Laura, that until 16 things are going forward on parental responsibility, after that the Mental Capacity Act applies. And we're talking about the young person's ability to give consent themselves. Okay, the law says that if we can support somebody who's 16, 17 and above to make a decision, then they should be able to do so. So it would be about assessing the young person's capacity and then seeing whether they could proceed on their own consent. There's a few things that we need to consider. One is if the young person's been given enough information to make a decision, because obviously you can only make a decision about something if you know what's involved. It's also important that the young person doesn't feel under pressure at all. They're not feeling like they have to make the same decision their parent would maybe make or their carers. So we call that duress. We have to be sure that the young person is not under duress. They're free to make a decision themselves, and that also they can share with other people the decision that they've made.
So what happens when a young person with a learning disability is 16 or above in terms of wanting to make a decision or their capacity being assessed? What does that look like?
What would happen really, what that would feel like to the young person is that the doctor or the nurse or whoever is suggesting the care would have a conversation with them about it, but it would be a particular sort of conversation because it would be what we would call a mental capacity assessment. And during that conversation, the young person would have information provided to them, and then it would be about them showing the staff member that they could do 4 things. And those 4 things are: understand the information about the decision they have to make, to be able to remember the information while they're having that conversation about the care or the treatment, to be able to do what we call balance or weigh up. And that's about thinking what would be the good things about having this done and what might be the risks or the less good things about it, and making a decision, thinking about those two things. And the fourth thing is communicating their decision. That can be verbally, or it could be maybe using some sort of communication skill like Makaton, or possibly even pointing to illustrations. It's really important that we gave the young person the chance to communicate however is most comfortable for them. But the assessment, the mental capacity assessment, would be looking at whether they could do all four of those things. So that's understand, retain, balance and communicate. At the end of the assessment, a decision would be made whether they did have capacity to make the decision, or whether we term it that they lack capacity to make that decision, and then there will be a way forward that we'll talk about in a minute.
So for parents who have always been involved in their young person's life and making decisions, especially around care and treatment, how can they be reassured that there will still be a level of some involvement, even if that young person can make a decision for themselves?
My expectation would very much be that parents who have been involved until the age of 16, very closely involved and very knowledgeable about their child's care, would continue to be involved and would continue to be very much spoken with by healthcare professionals. So that should not stop. And if that does stop, then I would, parents should raise that with healthcare professionals, that they have a concern. So I hope that is maybe reassuring in a way that you are not suddenly going to be shut out from decisions made about your child. However, the Mental Capacity Act does mean that if your child does have capacity to make a decision about some care or treatment, that they would by law be entitled to make that decision. So it would not be that parents are not spoken with, but it is, if there maybe is some not so complicated decision and it empowers your child. They are 16, they are coming towards adulthood, and they would have the same rights as everybody else to make a decision. So I think in that way it's a really positive thing, but to offer that reassurance that definitely involved parents should still very much be a part of that decision making.
Absolutely. So what happens if someone who's got a learning disability or severe complex needs doesn't have capacity to make decisions for themselves and are of the age of 16 or above?
I think it's simplest to talk about the age of 16 and 17. Okay, now between 16 and 17, it's a little bit confusing perhaps at first to think about, because there's actually two routes that decision making can take for 16 and 17-year-olds. One is to continue to seek parental consent. So it will be a continuation of what parents are used to up until the age of 16, and the clinicians may be happy to say until somebody reaches 18 that they will speak with parents and will go with the decisions that they are making. However, there is also another way that things can proceed at 16 or 17, and this is called best interests decision making. And what that means is, because the young person lacks capacity, the decision making would go more to the healthcare professionals, and they would look at the whole situation. They would talk with parents, they would talk with the young person and see what they were wanting, because although they may lack capacity to make the decision, they may still be very clearly expressing their preference, and that's really important to bear in mind. They would also think about the intrusion, the complexity, how burdensome, if you like, the intervention is. And they would put everything into what you could call a best interest making pot, if you like, and then come up with a decision that I would very much hope would usually be a decision that the parents are happy with and that they agree with. And that would be called the best interest decision. But the point is, if they're not seeking parental consent for 16 and 17-year-olds, the person that makes the final best interest decision is the healthcare practitioner. And although they're consulting with family, actually they're taking that decision-making power. So I think it's a little bit complicated, so it's quite a lot of information, but it's just important to remember for this age group of 16 and 17, it may be that parents will not really notice any difference or it may be that they start to hear about this best interest decision. They should be very much involved, but it would be very much more to the healthcare professionals side of things. So I hope that makes sense. It's always, there's some more information maybe people can seek afterwards if they're a little bit confused by that.
Thank you, that's helpful. So in regards to the best interest meeting, for a young person, if they need to have a particular procedure, for example, have their appendix removed, what would the best interest meeting involve? Who might it involve?
So a best interest meeting is an opportunity to get the key people involved in the young person's care together, to give everybody an opportunity to share their knowledge of the young person, to share what's involved in the procedure, to make a plan for how to make it as positive and as stress-free as possible for the young person. So it's really, really important. This is where the parents' contribution is absolutely crucial, because they have such a lived experience and knowledge of the young person and what particularly helps them when they're stressed, when they have new things happening, and how this can inform the professionals who are going to be carrying out the procedure. The people that I would expect to be present at the meeting would be, of course, parents, the young person, if that's comfortable for them, maybe even for part of the meeting. I would expect adjustments to be made at the meeting so that they can be fully involved. We would have the doctor who is proposing this appendix, did we say? Yes. I would expect perhaps a senior nurse from the clinical area who will be caring for the young person, whether, before and after they've had the procedure. If they are, for example, resident at a care home for any or part of the week, I would hope that a key carer would be present there. And you need somebody to take minutes of the meeting, preferably somebody who's not too involved in the discussion, so that they can make an accurate record of what's happened. And this would be shared with the people after the meeting. So you've got a really nice information source to show everybody clearly what's going to be happening and the decisions that have been made. In these strange COVID times, it may not always be possible to have everybody in the same room at the same time, but we have things like video conferencing and even a loudspeaker phone call. So again, the ideal would be that people were together at the same time. But if even that is difficult, it may be that different people could be consulted at different times. Maybe a parent is at work, for example. It may be possible that there could be a phone call in the evening, maybe from a clinician, to get some information and key points from them, their contribution to the meeting. That can all be pulled together. And so out of it, you would have what is called a best interest decision that hopefully everybody is agreeable to, and that will all plan how you're going to move forward when the procedure takes place.
That's really good. I think you've clearly kind of outlined what that looks like for me, so thank you, that's really helpful. So in terms of decision making, what happens when that young person with a learning disability reaches the age of 18?
So at 18, a young person actually is an adult. 18 is the age in this country at which everybody becomes an adult, regardless of whether you've got a learning disability or not. So when we've been talking about these two routes, if you like, that things can take, which is 16 and 17-year-olds still having their consent to their care provided via parental responsibility, parental consent, or this best interest decisions route. At the age of 18, it is no longer parental consent that applies. It is always the best interest decision route. So what I've just described in terms of best interest meetings, and if we're thinking about having the capacity assessment, this will always apply 18 and above. But to revisit, as I always am, that this does not mean that the involvement of parents is diminished. It will remain the case that parents should always be consulted. The reason I don't say always is we have to have the proviso that if there's something really urgent or life-threatening, that you would not be having a consultation process, that that healthcare professionals would be providing urgent care, and that would apply to everybody. So that is why I can't always say we consult with parents, because sometimes we have to act urgently. But other than that sharing of information, that consultation should always take place.
So what happens if a parent, for example, disagrees or strongly disagrees with a decision that's been made by a clinician or a practitioner about the care of their young person, what options do they have available to them in that situation?
There are options because, as I was saying earlier, the hope is that generally there would be agreement. But of course, sometimes there isn't, and sometimes parents feel this very strongly. So the options can be with the healthcare professionals to have, for example, another meeting or more discussions, maybe one-to-one, for example, with the doctor if it is about the surgical procedure, rather than in that with several people at a meeting. It can be easier one-to-one. They could request, for example, a second opinion from another doctor to seek reassurance whether the choice of the intervention is correct, whether they feel confident in what the medics are suggesting. They can perhaps go and seek extra information themselves, aside from what the healthcare professionals are telling them. So this could be, for example, contacting an organisation like MenCap, or maybe going to somewhere like Citizens Advice Bureau, because they're impartial, they're independent, but they've also got a good knowledge of what best interest procedure is, and what the parents can reasonably expect about their involvement and their decision making to be taken into account. If this is not finding a solution and the parents are still very unhappy, then what can happen is that there can be a referral to what's called the Court of Protection. And the Court of Protection are, as it says, an independent court. They're very, very powerful. They have high-level decision-making powers for people that lack capacity. And what would happen is that the healthcare professionals would provide a report from their view of what they think should happen, and then the parents would provide their view and their opinion, and the Court of Protection would make an independent decision. So it would take it away from the hospital, and they would make, and their decision would be final. So it is several steps away, but it is an option, and it's good that parents do know if things are not resolved locally, that they can request that things go externally to the Court of Protection.
Is there anything else before we conclude this session that you feel is quite important?
I suppose, Laura, really what I'd just like to finish with is for people to remember the Mental Capacity Act. It is the law that is applying for young people that are transitioning and need to make decisions about their care and treatment. So if you remember what the law is called, and then there's a lot of really good information out there that can be accessed. MenCap have excellent, clear, very useful information about the Mental Capacity Act. As a trust, we also have leaflets that talk about the Act and best interest decision making in standard format and best interests that people can access. So don't be afraid to ask. Staff should support you very much in this process, but it is at the end of the day about your children being empowered to have the same legal rights as everybody else, and that is really as it should be.
Thank you. So I really hope that from this session that you as parents and as young people have got a real understanding or an idea around decision making and capacity. And I just want you to also know that as healthcare professionals, as practitioners or doctors making decisions, that we are really about putting that child or young person at the heart of every decision. And we really want to make sure that the best decision is made for that young person. And it's about no decision about me without me. So I just want to say, if there's any more information that you might need, please feel free to contact us, and we'll be able to advise accordingly as well. Thank you.
Okay, thank you guys. I hope you enjoyed me and Val's video on consent and decision making. It's an interesting time recording that, but really useful stuff there. Val's, got expert knowledge on mental capacity assessment and decision making in regards to individuals who may lack capacity. And I know for many parents that's an area that can come as a bit of a worry when your child's becoming an adult, especially when you have made pretty much every decision, and if things begin to change. So I really hope that that addressed some of those concerns or questions around that. I think we're bang on schedule now, I believe, which is really good. Our next speaker, who really doesn't need any introduction at all, but I'll try my best, and he'll introduce himself as well, is a gentleman called Jamie Knight. Him and Lion will be presenting shortly. And Jamie is someone who I met for the first time in hospital setting, actually, when he was admitted. Jamie was a patient at BHRUT, but Jamie also has autism. And he's going to share his story and just his experience as he's an adult now, but going through that kind of period of transition, and just a little bit more light on kind of his world and his perspective. So stay tuned. And Jamie, over to you. Thank you.
Can people hear me?
Yes, we
Hello?
can.
You can? Cool. Let me share my screen to you.
Thank you.
And we'll find out if Teams is wanting to play ball today or not. Cool. How's the day gone so far?
Been good.
Yeah?
Good. Lots of information, I think. That's really useful.
Can you see my slides?
Yes, we can.
Can you see them when they change? Let me just change the slide. Still good?
Still good, yeah.
Cool. So roughly how many people are listening at the moment, do you think?
We've got 59 people in the meeting.
Cool. And how many of those are young people, do we think?
Oh. Some will probably be on with parents. I think we've got a few parents in the room.
Okie dokie. So this is a talk for the young people. This is a talk. This is a talk that I wish that I saw when I was their age. And parents, professionals, you're welcome to hang along. You're welcome to tune in. You won't necessarily like what I'm going to say, but you know, being made to listen to it might do you the world of good. So to start off with a bit of a disclaimer, this talk isn't about science. I'm going to share one person and I'm going to share my own anecdotes and my own examples. I'm talking about what I do and why, what I find effective and what I don't find effective. And I don't speak for all autistic people because that would be madness. I speak for myself, but I know that a lot of the lenses that I use are useful for a lot of other autistic people and beyond. A lot of non-autistic people find these lenses useful too. So Laura in her introduction referred to me as somebody with autism. Laura, what was the one request? It was that I'm autistic. Not someone with autism.
I'm sorry, Jamie, forgive me.
All right. Well, it's a great example of power dynamics, isn't it? So we'll come on to this one in a little bit and about how what is our default might not actually be effective, and then deciding who made up the default and when and stuff like that. But either way, I'm Jamie and this is Lion. So a very little bit about me. I'm going to structure this talk into two sections. I am currently in quite a lot of pain. So I'm not my normal bouncy self, if I'm honest. I have a spinal cord injury, it seems, and the tailbone pain is not appreciating the heat, to say the least. So today's presentation might be a little bit more bouncy than normal. But essentially, I want to talk about two things. I want to talk about myself and what I do for my job and what I do with my work. And then I want to talk about how I approach life and the lenses that I use and where they come from. But my hope is that by talking about myself and my work, you'll believe that I actually know what I'm talking about, because I don't have a bunch of letters after my name. But I think I am the only autistic person talking today. So if you want, actual experience, hey, that's me. And then the how I approach stuff is kind of what we've learned over the last 30 years and what I've learned working with other autistic people in that time. So about me and my work. So the real basic things are that I'm 31 years old. I live in London. I live in Romford. I live about 550 meters or so from the front door of the hospital. I'm waving in your direction right now, Laura, but you can't see me because there's lots of walls and stuff in the way. But if I was tall enough, you'd be able to see me. If I was a lot taller, thinking about it, maybe I'd need a ladder or something.
I live in London. I have my own home. I bought my flat a couple of years ago. Outside of the job that I'm talking about here, I also run a company that turns over best part of £250,000 doing financial compliance software. And I find words really tricky. In fact, Laura, I think when we met, I wasn't particularly verbal. My ability to communicate goes up and down based on a lot of factors. And one of them is pain. So if during this presentation my words get a little bit wobbly or my speech gets a little bit hard to understand, then I'm sorry about that. I'm kind of doing my best. If it gets really bad, I'll swap to assistive communication, and then you can hear me sound like a robot or a computer. So my day job is with the BBC. So at the BBC, I'm a senior research engineer. I specifically focus on digital accessibility, which is the process of making sure that everything we build works for the whole audience, whether they are people who are blind, people who are deaf, people who have a motor impairment, such as myself these days, or people with a cognitive impairment, such as being autistic, or a learning disability, or dementia, or hell, people who are just in a hurry, or holding a shopping bag so they've only got one hand accessible. That is what accessibility is. It's the art of making the things that we build work for as many people as possible, or trying not to exclude people would be another way of putting it. I've been at the BBC about 11 years. I used to once upon a time be the lead developer on iPlayer Radio, which was quite fun. But these days I work in the accessibility team. Outside of that, I also co-host an autism podcast called 1800 Seconds on Autism, which I co-host with Robin. We don't have a good link for it, I'm afraid. If you Google 1800 Seconds on Autism, we're the top link. But the BBC only has these ugly URLs. So I'll just have to give you bbc.in/3IY_G_NNJ, which is awful, frankly. But it's what we've got at the moment. And I am trying to improve that. I did build one in my spare time, but, you know, quite rightly, a bunch of people were not super keen about me putting that on the internet. So I still need to persuade them we need one of those. And a lot of people use the things that I make. So basically everybody who uses the BBC websites, apps, or well, any BBC service pretty much any day is using something that I was involved in or directly contributed to. But I also work for international standards bodies and stuff like that. So if you add it all together, including W3C work and stuff like that, it's about 2 billion people a day are using things that I was involved in, which is pretty damn terrifying, frankly. So very importantly, if you find bugs in any of these things, obviously Lion did them. But if you really like them, I did it. That's kind of how it works. Lion takes the blame and tries not to eat me, because that would be very awkward and messy. And then finally, because I'm a big nerd, one of my favourite things is that my work gets used in space. So on the International Space Station, I use the BBC website quite heavily. And the fact that it works up there is one of the projects that I delivered many years ago now, probably 6 or 7 years ago, to make sure that the website works in space. And it's kind of a joyful moment to be pinging an international space station, kind of like going, he's all going to space, squee. I also help people like Apple. So where I work with all the international communities and I talk about autism stuff and I talk about cognitive accessibility and I talk about digital accessibility, I've been lucky enough to be invited across to the States to go and work with Apple. So here is the lookout from the Steve Jobs Theatre across Apple's new campus over in Cupertino. And here's Lion looking particularly suave in the visitor centre with a nice blurry photo behind him. Finally, I have friends, which if you'd asked 17 or 16-year-old Jamie would have been a bit of a surprise. But I do. I have a lot of friends. I have friends who are very close. And in fact, when I was ill, one of the things that we feared most is that because I couldn't communicate and because I need such a specific environment to thrive, that somebody somewhere would assume that I didn't have mental capacity. And in order to ensure that somebody was with me at all times to keep me safe from the system, my friends got together and did a 24/7 kind of rota for the whole time that I was here. And I think Laura met Mike and Chris who are in this, and she also met Ollie and possibly the other Chris and some other people and Ed and other people like that. This surprises me quite a lot because as a teenager I didn't have friends. What I had was, if I had friends, they were always a lot older than me because generally speaking they're professional contacts. When I was a teenager I lived in some supported living. I was homeless for a little bit, but after that I was living in supported living and I hadn't been verbal for multiple years. And I had this funny situation where in one room they were trying to decide my goals for the next 3 months, like toilet training and learning how to make a bed. And, you know, not 100 meters away, I was sat in my bedroom building a website for Channel 4 for the new series of Come Dine With Me. And these two worlds never really collided. People didn't really understand that communication and the ability to do things are not necessarily as heavily correlated as people think. And as I said, I do things. I can fly a plane. I build cars. I build Lego models. I build mountain bikes. I don't do these things as much anymore because spinal cord injury. I'm a lot wobblier in the middle than I used to be. But these are things that I can do. They're abilities that I have. One of the things that I sometimes draw a distinction between is an ability, a capability, and a capacity. So I'm able to do many, many, many things. My abilities are the list of everything in my life that I could possibly do. But my capability are the things that I could do today, the things I'm capable of today. And my capacity is how many of those things I'm actually able to do. So, for example, I recently had my vaccine. I'm quite sore from that. I'm quite sore from other bits of pain. Haven't slept particularly well, so I probably shouldn't fly any aircraft today, as a general rule. So that's what I mean when I'll talk about ability, capability, and capacity. This is an important lens because sometimes I don't have an ability, so I need to learn how to do something. But more often than not, I find that it's not my ability that is lacking, it's my capability that's lacking. I'm never in a position where I have enough capacity to do the thing that people are expecting me to do. In fact, when I was in hospital and met Laura, the environment was damaging me so quickly that I built no capacity at all. No capacity for communication, no capacity for decision making in some areas. So yeah, capacity, so useful lens. I would say that I'm fundamentally happy. I'm thriving in my work and I do lots of cool stuff. I go riding with my friends. I go riding with support folks. I explore the world. I go to America. I do things that literally change the world sometimes, which is very, very weird. For a web developer done good who came from Somerset, it's really weird seeing things you've built on billboards and stuff like that, as often happens with the BBC. So that's about me and my work. And what I'm trying to get you all to listen to is that I'm, by neurotypical terms, successful, right? I'm autistic and I do things a different way, but I'm equal but different. One of the reasons why this presentation has to start this way is because for much of my life, the autism professionals involved in my life wouldn't actually listen to me about autism. Ironically, even after they've just read the book that I edited, they still didn't listen to me about autism. And I guess that's one of my fears today, that you've listened to lots of professionals today, and I'm sure they're very good, but here I am, just an autistic lad at the end of the day, telling you how I do things. So sorry if I seem a little bit defensive, I'm just used to professionals not listening. So how do I approach stuff, the meat of this conversation? Well, there's lots of areas that we could explore, but I think the three most important ones are identity, autonomy, structure, and support. These are the areas that kind of have the biggest impact on my day-to-day life. Let's start with identity, because that's kind of the foundation of everything. So I'm autistic. I don't have autism. There's not separatable from me. It's not a disease. It's not an illness. I actually quite like something known as the neurodiversity argument, which basically says that essentially neurodiversity is a lot like gender diversity or sexuality. There's a lot of ways that humans come and none of them are inherently better or worse than each other. So that poses the question then, what is autism? So when I'm talking about what I think autism is or what my experience of being autistic is, I'd split it into three areas. So the first is what I'd call the hedgehog profile, which is if you take my skills and you take the things I do and you draw them on a chart, you look like a bit of a hedgehog, because I tend to be really good at something or really hilariously bad at something. And I mean hilariously bad, like really, really, really bad at stuff. So a great example being crossing roads. I am really bad at crossing roads because my brain doesn't do motion estimate. If you go, how fast is that car going? I will try and find a benchmark that's around 10 to 20 meters from the vehicle, get a rough idea of how long it took to do 10 to 20 meters, and then give you an estimation in meters per second. I'm not very good at answering the question, will the car that's coming down the road hit you before you get to the other side of the road? Not very good at that at all. I used to get hit by cars a lot more, almost to the point where last time I got hit by a car, it was a Ford, a Ford Focus. And I swear my last thought just before it hit me was, thank God this isn't a Transit. Ford Focuses are nice and soft. When you have a preference for what sort of car to get hit by, you should probably accept you're not very good at crossing roads. On the other hand, some of the software and some of the coding stuff I do is genuinely really good. It's a real strength of mine. Ironically, communication is often a strength of mine as well, which is ironic considering I spend probably 2/3 of my time not able to speak at all, but still able to communicate. So the hedgehog profile is the first thing about autistic life that's really important, which is we tend to have strengths, really strong strengths. And it's about making the most of the strengths that we've got. So I make the most of the strengths that I've got with my work in order to subsidize and enable the support I need for the rest of my life. The second thing is that most of the autistic people that I know tend to have quite limited energy. Now, this might be because we're not very good at, it might be because the environment has too many barriers that affect our ability to sleep or ability to do things, or it might simply be something inherent to autistic people. I don't know, and to be honest, it doesn't really matter that much, which is the case for most autism research, which is it's not particularly useful for autistic people. It doesn't matter to me whether an autistic mouse model did or didn't react to a certain gene therapy. Doesn't matter. However, autistic people, typically we have limited energy, and we need to make sure that we use our energy in the way that benefits us the most and plays to our strengths. There's no amount of practice, repetition, educating that's going to make me good at cooking. And this is something that is really important. So, for example, I don't cook because if I have, these 10 energy bars of the day to get everything done, these 10 little energy batteries, I could spend 4 of them on cooking every day and still burn myself and still get it wrong over and over and over again. Or I could pay the £15 for somebody to do that for me, and I could focus on writing software or doing something that I find more productive or more enjoyable. Doesn't necessarily have to be work, it just has to be better. So a lot of autistic people, and especially myself, we have a lot of limited energy, and it's then making sure that we use that energy effectively. And then finally, one that's quite specific to me, but maybe not, is the concept of elephants. So I spent my entire young life being told that I was anxious. And the trouble with the word anxiety is it covers a lot of bases. Anxious is used to describe a whole host of different body feelings and a whole host of different situations. And what we tended to find is that I wasn't anxious, I had elephants. Now, elephants is a really specific feeling for me. It's the feeling of an elephant sat on my chest in pointy shoes. And for years, people told me this was called anxiety, and I believed them. But when we started pulling the language out, rather than referring to something as anxiety, describing the body feel, we noticed a pattern, which is that when I was starting to feel elephants, it was almost always because there wasn't a lot of structure. Like I didn't know what was happening next, or I didn't know what was happening tomorrow, or I didn't understand what the dynamic was in a certain situation. So we quickly understood that elephants was really just my sense of structure rather than anything to do with anxiety as such. So an analogy that I sometimes give is you could imagine driving an electric car that has a limited battery that's full of elephants. You're not going to get very far. And this is school. This is most work environments. This is most of the environments that I encounter. They are extremely energy intensive. They're not structured enough, and I don't get anywhere. So that is kind of one of the things that we learned. So when I'm thinking about autism, I'm thinking about the elephants, I'm thinking about the battery, and I'm thinking about the hedgehog profile. So when you add all of these together, it basically adds up to lots of, for me at least, lots of structure to help with limited energy and then focus my time on my strengths. Again, there is no point trying to spend another 6 months trying to teach me how to make beds or do washing up, for example. Oh, actually, washing up I'm not so bad at these days. That's probably an exception. But cooking. I used to have my cooking stick. With it, I could tell whether a sausage was cooked or not, because when it was the same brown as the stick, it was cooked. Brilliant. And then somebody brought me chorizo sausages and I almost burnt the bloody house down because I was waiting for these red sausages to turn brown, right? That was the same week I deployed code to a space station. It's not that I'm not smart. It's that my brain just doesn't work that way. And it's not a disorder, it's not a problem, it's just my brain doesn't work that way, and a lot of the environment around us makes assumptions that it does. So I touched this a little bit earlier on why I'd say that I'm autistic. So there's this popularity, a little bit of a history lesson here for those who don't already know. that autism is seen as a medical thing. Sexuality was seen as a medical thing once upon a time as well. In fact, possibly one of the greatest suspected or proposed autistic people in the last few generations, Alan Turing, was also gay. He was homosexual, as I put it. And at the time, you could get diagnosed with homosexuality, and you could have medicine that would make you chemical castration, basically, to cure you of this terrible disorder. We are at the same place with autism. Autism is currently medicalized. It's currently part of the medical model, but it doesn't necessarily belong there. Now, that doesn't mean to say that autistic people can't have medical problems. For example, I know plenty of autistic people who are epileptic or ADHD or have many other health problems. But autism itself, that underlying thing, that strength, that energy pattern, and the thing about elephants and the thing about not being great with change or not liking change, we choose to pathologize them, or should I say the medical establishment choose to pathologize them. And for me, I was brought up teaching that I had autism. Autism was a thing I had. That was a really bad idea, because when I got to 25, I almost dropped dead of gallstones, because I'd been spending all of my spoons and all of my energy trying to not be autistic, trying to be as neurotypical as I could be. I had failed completely. And the people around me had failed me, because what they did not understand, and what a lot of autistic professionals, a lot of autism professionals and a lot of parents don't understand, is that trying to treat autism as a force and the person as or a disease and the person as separate is a fool's errand. It doesn't work. I'm male, I'm right-handed, I'm also autistic. These are all attributes of my identity. And it was working out my identity and then defending my identity that has been critical to my success and my thriving. So going back to Laura's introduction, I really do not have autism, because autism isn't a thing you have. It's that fundamental. Anybody who says to you that autism is a thing that people have probably doesn't know what they're talking about. Grr, fighty words today from me. I like it. When I'm a little bit in pain, I tend to be a bit more snappy. Normally I'd be making more jokes, but my tailbone hurts. It feels like someone's shoving a piece of Lego up my bum. It's really not a very nice feeling. Although if it was a different shaped piece of Lego, it would be a different story. But anyway, that's a chat for a whole nother day. The second thing I want to talk about is autonomy. Ooh, when I get back on my slides at least. There you go. Second thing I want to talk about is autonomy. So we talk a lot about independence, but we never really talk about the process that independence comes from. So that's kind of what this is about. In my experience, all independence I've ever had has grown first from stability. Making somebody independent to try and make them stable, I've never seen that work successfully. I don't know of any autistic people that that's worked successfully for. Independence starts from a position of stability, of solid mental health, of being being relatively settled. The next stage from stability is autonomy, which is about decision-making power. In fact, I would go as far as to say that autonomy is much more important than independence is, because independence is then being able to make the decisions and act on the decisions. Now, again, when I was younger, my independence was valued far more than my autonomy, so it was really brittle. I had this independence where I could choose what I wanted for dinner, as long as it was one of the 3 things I could possibly cook that I was able to cook. But of course, none of those things I was capable of cooking at the time. I didn't have the capacity. So in the end, I ate nothing. That is because what had happened is people had confused the ability for things I can do myself with the things I could choose to do, and had limited the two together. One of the ways that I explain this is that autonomy is when I can act as and for myself. So autonomy is when I can be autistic, when I can respond to things in an autistic way and have autistic preferences. And acting for myself means that when I truly have autonomy, when I need to be, I can be selfish. Because ultimately that is a cornerstone of independence, the ability to make decisions that affect others in negative ways and to be able to evaluate and make that decision yourself. So when I have autonomy, I am both acting as myself and for myself, which doesn't mean to say that I'm selfish by default. It's the ability to be selfish if you need to be. I think everybody in this conversation, everybody listening to this, can think of a time of their life where for their own safety, security, mental health or whatever, they had to be a little bit selfish. We do this every day. You know, the first part of your first aid training says, don't become another victim, don't run into the fire and add another body to the flames. Gosh, that got a bit dark, didn't it? So another part of being autistically happy is that I don't mask. I don't pretend to be neurotypical anymore, because it doesn't work. All the neurotypicals around me can tell that I'm not neurotypical. It's exhausting and it doesn't work. Every time I mask, every time I cope, I am actually taking away an opportunity to improve the environment and to improve my life and the lives of others. One of the things that's really important, and this is known as social model of disability, is that the thing that disables me is the environment around me. It's the things that are built. It's the attitudes around us. It's what people think about me and think about people like me. When people set expectations too high, I fail. When people set expectations too low, I become trapped. But the good thing about the environment is that you can modify it. You can change the environment. You can exert control over the environment, and you can have autonomy over the environment. And by doing that, I remove the things that disable me. I'm still autistic, but I'm not as disabled by the environment. They're two different concepts. This is known as the social model of disability. It's very different to the medical model, which puts the problem inside the person. The social model puts the problem inside society and the environment society creates. So to give some examples, this is Lion, or this is an illustration of Lion. He's very, very special to me because Lion goes everywhere with me. He's my partner in not doing crime, because I don't do crime. But if I did crime, he'd be my partner in crime. He'd be the getaway driver. Probably the getaway driver. He has trouble reaching the pedals. And he goes everywhere with me. So here's Lion in a Radio 4 studio underneath the Space Shuttle Endeavour. Here's at one of the podcast recordings. That's Lion snuggled up with a 1,000-mile-per-hour land speed record car that they were halfway through building when I went to visit them to talk about neurodiversity and autistic hiring and stuff like that. So Lion goes a lot of places, and Lion's very important to me. Now, of course, to a lot of people, Lion was a problem. I spent most of my youth with people trying to get me to not take Lion everywhere with me, because people felt that having Lion would mark me out as different and that would be a problem. It's actually quite the opposite. I've walked into meetings with extremely powerful, important people with Lion in my lap, dressed as Tigger, and they haven't batted an eyelid because I'm genuinely being myself, which is more important than a fake mask put up to appear professional. Lion makes me very happy because Lion is an expression of me being me taking control of my environment and control of the expectations of others. I've got a 4-foot Lion that goes everywhere with me, and it is awesome. But Lion isn't the only tool that works. I also do things like use sippy cups, because frankly, cups are a pain in the ass. You knock them over, they spill their contents everywhere. That's a stupid design. You know, only neurotypical people could come up with that. I wonder, actually, maybe we could get neurotypical people some sort of therapy, maybe call it, I don't know, applied behavior analysis, or, I don't know, positive behavior support, and, you know, see if we can teach them the first 100 prime numbers, something like that. See if we can bring them up to a reasonable standard of prime number knowledge, because, of course, it's utterly wrong that they don't know the first 100 prime numbers. Anyway, I'm being snarky. It's weird, isn't it? Because sometimes one of the things I asked Laura to do with all the introductions today is I asked her if she would introduce everybody as blah, 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 who isn't autistic. Because if people are only going to say, oh, Jamie is autistic, then surely they need to point out who isn't as well, because otherwise, why the fuck are they talking about it? Oh, there's a swear word. They'll come out sometimes. The autistic community, the autistic medical community is mostly run by people who are not autistic. We wouldn't accept this for any other community. We wouldn't accept this for gender or for sexuality. But for autism, we do. And that will change over time. Anyway, sippy cups. Sippy cups work. When you knock them over, they don't leak, which instantly takes away, I don't know, 1/5 of all the energy that I used to consume. Literally 1/5 of all of my energy was spent not knocking things over. And we didn't resolve it by stopping me from knocking things over. We resolved it by making sure that it didn't matter if I knocked something over. Literally, this is the difference between being able to speak and not being able to speak for me some days. The margins are that small. Another thing that we worked on was sleeping really well. So if I need energy in the form of spoons or batteries, I get that by sleeping really well. And one of the things that we learned from a long time ago is that my perception of the size of the room changes a lot. So if I'm lying on a flat bed, the room can be the size of a cathedral, where I'm the size of a fly, and then minutes later it can feel like I'm sat inside a shoebox. This is not good if you're trying to sleep. So we did something really simple. We did a bed with sides that I could see with my glasses off, so I knew how big the room was, and I literally doubled the quality of my sleep overnight. These sorts of understanding, this sort of understanding of the environment, it didn't change what I was able to do, but it gave me capacity, and then the capacity meant that I was capable of doing more things. To some people in my life who knew me when I was 17, where I hadn't talked for 2 years, where literally my goals for the month were, toilet training and making a bed sheet, they would not understand the Jamie you're communicating with now. They wouldn't believe it was possible, but here we are, because we worked it out, because we engineered the problem. We worked out what things took energy and what things gave me energy. Another example is a less hostile environment. This is the hub in the middle of, it's the autism hub in one of the shopping centres. I used to go there quite a lot. In fact, some of the work that I did for Glastonbury a few years ago was done sat in here sorting some stuff out. It was really cool. They moved a satellite for us, so that was quite cool, having all of that come online. Environment is really important to me because it's the environment that takes away the spoons, and then it's the environment that disables me. And for me, this is what a good environment looks like. It's low-level lighting, it's predictable, it's relatively simple. It's cozy and snug, and I feel safe, which is lovely. So my bedroom looks like this, kind of like a giant 5-year-old's bedroom, but that's all right. My bed has the side on it. We added some little window vanes, mostly so that I could get a breeze through when it was hot. And it works really well for me. This is the room that I can use to sleep and recover. We also added other things as well that you can't see in this photo. So for example, we have big graphics on all of the corners, and we have long lines and stuff down the wall like that, those little flags. The reason for that is to add enough visual information that my brain doesn't perceive the room as changing size on me. Stuff like that. Small tip, but makes a huge difference. Yeah, I'm 31 and I have a kid's bedroom. All right, whatever, works for me. Now,
Jamie,
trying to get past that is important. Yeah?
Jamie, I'll stop you very quickly. Just because I'm conscious of time, I just want to give you some heads up. We've got about probably another 3 minutes to spare. How are you doing?
How long?
3 minutes.
3 minutes.
I just wanted you to have an idea, just to kind of see where.
This definitely isn't one of my good presentations. I'm in too much pain, which is one of the things we were trying to work out, right? Which is, where's the pain threshold for presentations?
I think it's fantastic. There's lots of stuff in the chat. I just wanted to let you know you're doing fantastic, but just a couple more minutes.
Normally less grumpy. So to make it very simple, one of the ways we do my structure and support is that I have routines. I have a morning routine and an evening routine. Someone comes in to do those with me. And part of having a good routine is to give up. In order to maintain my autonomy, my decision making, I occasionally have to give up control. So for example, with the evening routine, Mary is allowed to boss me around and do things. In fact, I ask her to prompt me, remind me, tell me to do things. I'm giving her that control because ultimately that's how I get my teeth done and all of my evening routine done, which is what I want to do, which is my autonomy. So sometimes to gain autonomy, I have to give up a bit of control. We also have this lunatic on the right. This is Ollie. He does a huge amount of support with me. We go mountain biking, we go traveling the world, we go do all sorts of things funded by Access to Work and the like. Finding the best support for me wasn't a case of just finding a support agency. Most of the support agencies didn't have a clue. So it was finding people that we knew who were able to do that sort of work. Or in the case of Ollie was already taking me to events and already helping me do things. So it was a case of formalizing the relationship and getting the right paperwork in place. I'll skip this, but basically I hang around near my home because otherwise I get hit by cars too often. So, stay near home, don't get hit by cars. So this is probably the most important graphic of the whole presentation, all the way at the end here. I think of my life like a bridge, right? The foundation of my life is identity, that I'm autistic, that there's nothing wrong with being autistic, and that when medical people say with autism, they're immediately discrediting themselves as somebody that I should listen to, almost always, because it shows that they haven't hang around with autistic people. In fact, most autism professionals do more harm than good, which is pretty dangerous. That identity is a foundation, and from that I can build a structure that works for me, which is my routines, and I can also understand what my skills are. I can then take those skills and I can manage them via an organisation such as the BBC, and I can take that structure and I can use support, and then I can achieve more. And ultimately, the work side of my life and the home side of my life are both balanced against each other, and together they hold up my goals. So by having the work and home life, which is built on managing my skills and my support and structure, all of it on a foundation of identity, I get lots of really cool stuff done. So thank you for listening. And that was a very bad presentation by my normal standards, but it'll do. Also, ow. I'll have a look in the, if anybody has any questions, go for it.
Thank you, Jamie. No, you was fantastic, and thank you, because I know you said you was in a lot of pain. I want to apologise actually, because we did have a conversation actually, so I do apologise for saying you have autism rather than you are autistic. So I do want to apologise. Any questions for Jamie?
Yes. Can Jamie put that link back up again? That was on his end slide, please.
Oh, okay. Yeah.
Oh, spacedoutandsmiling.com. Yeah, sure. Let me pop that back up. Something like that one.
You might have to share your screen again.
Ah, let me find the button.
Thank you.
There you go.
I was just going to read some positive comments actually. Abby, there were some comments that people had concerning Jamie's.
Yeah, so someone said, interesting presentation, Jamie. Thanks for sharing. Thank you, Jamie. Brilliant for helping people understand. I'm just going to scroll up. Yeah.
Oh yeah, really interesting to hear Jamie speaking and telling us what real life is like for him. And lots of reactions, hearts and thumbs up.
That's very nice.
Thank you. Brilliant helping people understand.
Interesting presentation. It was really nice.
So lots of visuals there. So thank you. Has anyone got any questions for Jamie very quickly before we kind of summarise the event very briefly?
If I have anything, the slide, is it possible to have it?
Copy of the slides?
Yes, please.
Yeah, they need to go through BBC external comms, so there'll be a delay whilst they make sure that I'm not doing anything too naughty.
So Jamie will get back to us on that. That's fine. Lillian, you've got your hand up. We're only going to take your question just because of time, but go for it.
Yes, Jamie. Thank you very much, Jamie, for that. That was awesome. Just wanted to ask you, do you ever do things like mentoring young adults who are autistic? Is there any avenue someone could reach you out, or other places? Do you mentor young people with? Have you ever done that? Working? Okay.
I have done it, and I just run out of time.
Basically. Okay. That's all right.
There's a great organisation called Autism Forward.
Okay.
Autismforward.com. Or actually, I think it's autismforward.org.uk. They fund autistic people to mentor other autistic people. So that'd be a really good organisation to chat to. They've got some really good stuff.
Perfect. Thank you very much, Jane.
Thank you. And we'll add that to our virtual goodie bag that we'll send out over the next 1 to 2 weeks as well. Thank you. Thank you, Jamie. Really appreciate that. I'm just going to quickly summarise, and then I'll hand over to Catherine Halford, our Chief Exec, who will close the event for us.
I'm going to go lie down, so I'll see you all soon. Bye.
Sorry,
Bye.
Chief.
Thank you.
I do apologise. I do apologise, our Chief Nurse. So just, in summary, we started off the conference with essentially from the hospital and working outwards. We spoke about what the role of the LD nurse in hospital is during transition. The key points that we highlighted was the transition plan and utilising that at different appointments. You also heard from Dr. Keane, our paediatric consultant, and talking about what his role is when that young person needs to be transitioned into adult services, especially when they're known to tertiary centres such as Great Ormond Street, Royal London, making sure that those small conversations are being had with multiple teams, so that actually that young person isn't lost and parents feeling like nothing's actually happening. Straight after that, we went into kind of community setting. So we had Dennis speak to us, who quite fortunately certain boroughs do have a transition nurse, and he's one of them in Barking and Dagenham, who spoke specifically about what his role is and what that assessment looks like, what the criteria is, how a referral was processed, and essentially the evidence that needs to be gathered to make sure that this young person is applicable for the services available. And you also heard from social care. We had Sarah from social care, who's a consultant social worker on transition, who was able to shed a bit more light on if it's a young person that's got complex health needs or social health needs, or social care needs, sorry, and what that referral process looks like as well. And actually, she mentioned quite clearly about her relationship with schools, who will let her know of those young people at that 14 years old age, and then she begins to start that working process. And then in terms of when that young person becomes an adult, we had Nicola Carter, who's a learning disability community nurse, who spoke specifically about the things that will be involved in terms of hospital passport, in terms of annual health check or annual health action plans, sorry, that is required for that adult. And that's making sure that things aren't being missed, annual health checks, but also work such as desensitization, especially around blood tests and things like that, and pharmacy reviews of medication that will help that young person. Shortly after Nicola, we had the NELF team in terms of Rachel Penny and Masuma, who spoke specifically about positive behavioural support, which I think this was really crucial in highlighting some of the things that can really help parents of young people with a learning disability and or autism who may experience behaviour that can be challenging, and ways in which parents can be equipped to know how to handle that, and some of the training sessions that are available. And I'm sure many parents on the call may be interested in that, I'm sure, and even staff and professionals. Me and Abby had a brief chat about we should probably go on that training as well. And then that brings us on to shortly after that was our video, of course. Myself and Val talking about consent and decision making. Again, another crucial part of an important point in transition that many parents often ask questions about. That how can I still remain relevant and part of that key decision making when my young person becomes an adult? And I really hope that from that video, it really captured some of those difficult questions. And of course, to summarize or to end off, we had a really, really good real life example from Jamie of just his experience, of just, what certain tools he used. He mentioned specifically the ACC, which actually some of you might be familiar with, some of you might know of, a communication tool that individuals with who are autistic use, or even just with nonverbal communication. And I think that's just really important, and touched on so many different things in his presentation, and very well delivered. And that just kind of brings us to a close. Of course, this is the first transition conference that we've put on, and the hope really is to, one, address some of the questions that many parents have, which is what is available, what do people do, and what are individuals' roles? And I really hope that this transition conference has highlighted that. But I'll now hand over to our chief nurse, Catherine, who will kind of close the event for us quite kindly.
Thank you. I think it's been a splendid afternoon. I haven't heard all of the presentations, but I've heard a lot of them and have dipped in and out, so that's been really good. And I did like your video, actually. I thought that was very good. It's quite difficult to do it in a video format, isn't it? So thank you very much, and came in at the end of Jamie's presentation, which was super. And I think absolutely, it's taken you through the journey from hospital out and what happens next. Morgan talked at the very beginning about transition hospital. It's all very different. But I think the key thing through the conference is that everybody needs to know what's going on. You need to have that consistency of message and consistency of communication with parents, carers, the individuals themselves. I would really like to thank the team for pushing this conference on. It had a really good range of speakers and flowed really, really nicely, and that doesn't happen by accident. So thank you very much indeed for all of your effort in doing that. I think it is the first of several, so that also is really good. I've learned a lot this afternoon, which is really very good. I always like learning new things, so that's great. I hope you have, and I hope you haven't had to swelter your way through the afternoon and are able to go and enjoy some of this nice sunshine this evening. Thank you very much indeed.
Thank you.
Thank you,
Thank you, Catherine.
Thank you.
Thank you, guys. And just lastly, just to mention, I mean, this conference was recorded, as you guys are aware. And what we will be doing is sending out, for those who might have missed different parts, as I said, over the next week or two, we'll kind of gather all the links that people have mentioned, and for all guest speakers as well, any sort of links that you want to make available for that goodie bag, please kind of send that to me, so I can make sure that's in that virtual goodie bag, and we'll send that across. And if there's anyone who may have kind of registered via Eventbrite and not necessarily through Charlene, please write in the chat your email address, just so that we can capture you and send it to you as well. And lastly, there'll be a feedback survey that's already dropped in the chat, I believe, or about to be. And please, 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 as it's the first transition conference, we want to hear your feedback. We want to hear how you found it, what we can do better going forward. And once again, thank you so much. I want to thank every guest speaker. Thank you for being available. Thank you for putting up the presentation. And thank you for the schools that contributed in terms of sending it out to all the parents. And thank you for parents and young people that are on the forum. And of course, healthcare professionals as well. The only thing I can say is, as healthcare professionals, that we continue to learn, and hopefully we'll continue to get better at making transition a smooth process for everyone. So thank you very much, everyone. Have a fantastic evening, and please fill out the survey.
Just one last thing, I think, to jump in. I don't want to take away from Laura's wonderful close, but just to add in one person to thank in particular is Laura, I think, who's been a real linchpin in pulling this whole thing together and organising the whole conference. Thank you.
Thank you. Thank you, guys, and take care. Bye, everyone.
Thank you. Bye-bye.